and I think that's why he managed to survive and get to the hospital in time. So I think Aaron quickly inserted the intra-aortic balloon pump. This was done like I think almost 10 years ago in balloon pump, and via the LAD and the SIRC, and then had the aspiration thrombectomy done. And this is the procedure after the ballooning. Then he implanted a 3.5 times 14 stent into the left main, and then wired the SIRC and dilated the SIRC with a POBA. And this is the final angio showing a reasonable result with a TIMI2 flow down the LAD.
I know. Yes.
Yeah, I'm not sure why.
I know. Yes.
I cannot advance.
Very, very clear. The picture very clear. Yes, very beautiful.
Apologize. I'm not sure why.
Yeah.
So he had a complicated post-operative PCI. Cause had to be intubated. The ECMO had to be inserted because we don't have impella. Developed multiple complications with sepsis, hematoma, clotting disorders because of the quite significant blood transfusions, and then had also LV thrombus. But fortunately, because of his young age, he could be weaned off the ECMO after about 9 days and was discharged after another week. The EF improved from 15 to 35%, and subsequently went home and had another PCI to his distal right coronary artery. So the patient did well. Look at the unprotected left main PCI registries because there are very few, if any, major randomized trials in the ACS patients in the left main. This is one of the large randomized trials. This is a data taken from the British Cardiovascular Intervention Society. They have a big volume of patients because it's a national project. There were about 5,000 over patients in this series of unprotected left main PCI. And in their series from 2005 to 2010, there were about 47% had non-STEMI, and STEMI was 15.5%. So in their cases, most of their patients were actually ACS rather than stable IHT, in contrast with our data in Singapore. And in this ACS patients, about in STEMI patients, about 40% had cardiogenic shock. So quite a significant amount with a very serious condition at presentation. And intra-aortic balloon pump was used in about, again, 40% in these STEMI patients. So if you look at their mortality in unprotected left main clinical presentations, we know that, of course, with stable IHT, the mortality risk during PCI is relatively low. In their series, it's about 1.4% at 30 days. If you have non-STEMI, then it goes up to about almost 9%. And if you have STEMI, then jumps up to about 28%. And of course, at 1 year, the mortality rate creeps up as well. Of interest is to note that in patients who present with shock, particularly if you have STEMI, you have a very low rate of survival, as you can show in this lower panel of the graph. This is the patients who have STEMI with cardiogenic shock and non-STEMI with cardiogenic shock fare also severely worse compared to patients who present with non-cardiogenic shock if you have ACS. So if we look at our own heart center data, our patients who have stable IHT fare about the same. About 2.1% of our patients pass away at 30 days. With ACS is about 21%. And if we look at the STEMI patient cohort, then it's about 41%. So quite similar to the Western kind of data population that I just showed you earlier. Other thing to be aware of is that in this same registry, if you are doing PCI, it depends on how many you are doing. Sorry, I seems to have jumped out from here. Can you see my slides?
Not yet. Yes, not yet. Maybe problem to share. The problem with the sharing.
Can you see my slides now?
Yes, okay.
Sorry.
You went in presentation. Yes.
Yeah. So the patients who for the operators, if they do more than 16 cases of unprotected left main, then your mortality risk becomes low. So you need to be careful about how many operators can do left main PCI, I presume, per center, because otherwise you won't get your volume up and reduce the mortality rate. So what are the determinants of mortality at the 30 days? If you have stable IHT, basically your age is the only determinant factor that they could, independent determinant factor, age more than 80 years old. But if you have STEMI and non-STEMI, then the age as well as pre-procedural cardiac shock, peri-procedural ventilation, and severe LV dysfunction really reduces your survival outcomes. And then, of course, again, like I mentioned, if you have an operator who do more than 16 or equal to 16 cases of unprotected PCI left main a year, then the outcome is much better compared to those who do less. Another thing to be aware of is that patients who present with a totally occluded left main with ACS, as I showed you earlier in the case I shared, the risk is really very high. If you have a STEMI with the totally occluded left main, then your mortality could be more than 60% or so, versus maybe even less than around 20% if it's not totally occluded and without cardiogenic shock. So I think it's important to define the anatomy and get an assessment about the risk. So I think what are the kind of strategies we can do to treat patients with AMI, particularly with unprotected left main with cardiogenic shock? This is an article that is quite well presented in CAF Cardiovascular Intervention last year. You can look at it in the reference below. But to summarize, basically, vascular access, you need to think about what kind of access you need to do to do the case. as well as alternative access for implanting IABPs or other circulatory support devices. Need to think about the anti-thrombotic management in terms of intravenous anticoagulants as well as antiplatelets, having in mind that there may be some issues about absorption if you are in cardiogenic shock because of gastric motility issues, that kind of thing. And of course, PCI strategies, I'm sure all of us know what to do for these patients, but also very important because they are very complex patients. Post-procedural care is very important here for patients who have this cardiogenic shock. So to conclude, I would like to say that elective unprotected left main PCI have similar mortality outcomes at 6 years, especially with the syntax score low, then you can do quite equivalent outcomes compared to CABG. Of course, higher volume operators show less mortality rates compared to people who do less than 16 cases a year. In patients with ACS with unprotected left main PCI, then they have significantly increased acute and long-term adverse outcomes compared to stable IHD patients. And lastly, the patients with STEMI really have the worst prognosis of all, especially if you are in cardiogenic shock or had cardiac arrest or had a totally occluded left main lesion. In the culprit shock trial, if you are in shock with unprotected left main, then you should only do the culprit vessel only. So I'd like to thank you all for listening. Apologize for the hiccup in the sharing of the screen, and I'd like to invite you all to my Sing Live meeting next year. It's going to be a virtual 21st to 22nd January, and registration is complimentary. So I hope to see all of you there. Thank you very much.
Thank you very much for the very interesting presentation about the intervention in the intervention in the acute coronary syndrome and the CCS. Yes, it is very interesting presentation. I would like to move to the next presentation. After the pre-presentation, we had the 10 minutes for discussion. Yes, thank you. Yes, the next presentation, I invite Dr. Wan Lee present the tip and pitfall to perform left main physiologist evaluation. This is the expert, foreign expert from the Arizona. Dr. Lee, please. Yes.
Thank you, Professor Nya, for such the kind invitation to be to participate in the Vietnam National Heart Association meeting. It's a real pleasure and honor to be back here again this year. It's a real honor as well to be joined by my fellow expert panelists, Professor Koh and Dr. Bin, and I'm looking forward to the interesting discussions. So I'm going to start by presenting this lecture on tips and pitfalls to perform left main physiological evaluation. I have, these are my declarations of conflicts of interest. So what are the anatomical features of left main disease that make it special? First of all, there's a lot of variation. Not all left main is created equal. You can have ostial disease, you can have mid-shaft disease, you can have distal bifurcation disease. And then there are multiple bifurcation variants and different Medina subtypes. 111 is and 011 are considered the true bifurcations, but you have many other combinations. Occasionally, it's more than a bifurcation, and you can have trifurcation. You can have very complex takeoff angles, especially of the circumflex. There is frequent coexistent downstream LAD and circumflex disease. And there is frequently the presence of CTOs as well, whether they're in the LAD, the circumflex, or in the right coronary artery. And in post-CABG patients, protected left mains, you can have very complex physiological interplay between the bypass distal segments. So where does FFR currently sit in the SKY expert consensus? This in the United States is the last document from 2014, so it's a little bit out of date, I would say. They say that at that point, it's definitely beneficial that FFR can be performed for left main evaluation. They say that in stable ischemic heart disease, so not ACS patients, medical therapy is indicated for an angiographically indeterminate left main stenosis when the FFR is greater than 0.80. Notice that they use very carefully the term intermediate and not severe. So even if the stenosis is greater than 70% and the FFR is greater than 0.80, they are not committing to the statement there. And then possibly beneficial IVUS with a cutoff of MLA of 6 millimeters squared. And then, at that point, they were saying that OCT should not be performed to determine the functional significance of left main disease. And I think that statement probably today is still true. So how good is coronary angiography in the left main at detecting significant disease? This is a simple paper from Germany from 2007. They took 51 left main patients with between 40 to 80% stenosis. They performed FFR, then they blinded the cardiologists. They had 4 senior cardiologists. None of them correctly categorized more than 50% of the angiographic films. And there was also very large inter-observer variability, and unanimous or agreement between all 4 cardiologists only occurred in 1/3 of cases. So angiography is not great when it comes to intermediate stenosis to decide whether something is significant. And that's a very important message. As we all know, there's a wide spectrum of coronary physiology modalities. The one that we know and love the most and are most familiar with is FFR, and that's hyperemic evaluation. And then obviously there are these large body of non-hyperemic pressure ratio ways of evaluating physiology. You have whole cycle, PD over PA, where the threshold is 0.91 and above. And then diastolic subcycle, for which the most famous is IFR with Volcano. And then in the United States, the second is RFR. So FFR, IFR, RFR, and then some people use PD over PA as the first screening tool. Where has left main been in the major prospective randomized control coronary physiology trials? All of the FFR randomized trials excluded angiographic left main. So there's no representation at all in FAME 1, 2, or as of yesterday, FAME 3. There is no left main disease in FAME 3 as well. In the IFR papers, for the most part, there is no left main except for a very small cohort in IFR Sweetheart where they actually allowed left main patients to be included, but you can't draw any conclusions from that group of patients. How is FFR used in left main disease? Mainly in pre-revascularization in assessing significance. The other less important ways are following main branch stent implantation, after side branch angioplasty, and after side branch stenting. But for the most part, it's just assessing the significance. This is the summary of the papers that have been published on left main deferral and FFR in prospective observational studies, starting from 2001 to 2009. And you can see that generally they were quite small studies, 54, 27, 51 patients. But then they started to get larger towards 2009. And that is the last paper on FFR prospective observation, because beyond this, everybody decided that they had answered the question. And the follow-up was for up to 3 years. And they used quite aggressive FFR cutoffs in the early phase, 0.75, and then in the later phase, they used them 0.80. When they meta-analyzed all of those papers together in this study by Malidi and CCI in 2015, they found that overall, when you took all the data together, that FFR deferral is safe when composite MACE endpoints were compared. And the follow-up, remember, was between 2 to 3 years. So FFR is safe. What about IFR? Until recently, there was no IFR data with regards to deferral. In the middle of this year, however, Warisawa et al. From the Defined Left Main Registry actually published their version of safety of long-term deferral with IFR. Here, they had 340 patients enrolled in a multi-center observational study, and they were followed for 30 months. Half of them were IFR deferred and half of them were IFR revascularized. The deferred patients had more distal disease, less mild disease. And then revascularized patients, only 9% had isolated left main, 12% had CTO. For the most part, half the patients underwent PCI and 44% underwent cabbage. And they also showed the same thing, that deferral is safe based on an IFR cutoff of 0.90. So IFR has now some supporting evidence as well. What is the theoretical superiority of physiology versus IVUS in left main? I've always been very uncomfortable with using one single number to decide for everybody, because we all know that 6 millimeters squared in a very big patient is not the same as 6 millimeters squared in a very small patient. And that has always been a bit disturbing, especially when it comes to Asian populations when people are smaller. The good news is that a lot of the literature does still support 6 millimeters squared, but some of the literature from Korea especially moved towards a smaller diameter of 4.8 millimeters squared. So it's not 100% consistent. Physiology takes into account the effect of additional confounders, patient size, the length of the lesion, because 6 millimeter is just one slice. And if the lesion is very long, that's not the same. The mass of the myocardium perfused, and it also takes into account infarcted myocardium. So lots of reasons why FFR might be superior to IVUS. There are no head-to-head FFR versus IVUS comparison deferral studies in prospectional observational studies, but Javier Escanet's group tried to at least lump all of the IVUS studies together versus all the FFR studies together and see if there was any difference. And in this paper, the predictive power appeared to be similar. So probably similar. How does left main correlate with IVUS in IFR? So this is a very interesting paper from Stephanie El-Haj and Amir Lerman's group in Mayo Clinic, Rochester. They tried to continue to add more supporting literature to IFR with regards to deferral. So this is not a deferral paper, but what they did was they enrolled 125 patients. They looked at all patients with IFR less than or equal to 0.89, so positive IFR, and they looked to see at what point does the IVUS MLA correlate with that number. And surprisingly, IFR positive number correlated exactly with IVUS MLA of 6.0 millimeters squared. And there was no difference even when the BSA was factored in. So this kind of supports that confluence that it's probably all correct, that 6 millimeters squared, IFR at the correct threshold, FFR at the correct threshold, they all are probably the same thing. So, this I think hopefully makes those of us who use IFR a bit more comfortable. What are the theoretical issues with FFR, hyperemic physiology assessment in the left main? In the left main, there are many tandem lesions, either within the left main itself or downstream the left main. As we all know, if there is downstream disease, the left main step up in between may be lower. And so you falsely elevate and make this area falsely negative if you don't take into account the downstream disease. So to rule out this effect, you have to put your wire as far downstream as possible when you're evaluating tandem disease. You must go all the way to the distal LAD or distal cert before you make the call. You cannot just put your wire in the first 2 centimeters and decide everything is okay. So if initially you have this disease, and this could be the LAD, right? And you stent it, you cannot stop. You must go back and reevaluate again, because the second time you do it, now that you have gotten rid of the downstream disease, you may actually unmask the true positivity of the left main disease. So that's a very important message. What about contralateral lesions? Bill Fearon's group with Andy Young published a very elegant series of papers asking the question, if you have disease that's very severe in the LAD, for example, will it affect your circumflex measurement? So they started with this machine contraption, and they showed in JACC intervention in 2012 that with mild to moderate disease in the contralateral vessel, FFR is not affected. However, in severe disease of the contralateral vessel, the FFR in the vessel that you are evaluating is actually falsely elevated and therefore falsely negative. Okay, so they then took it one step further in insert cardiovascular intervention in 2013, and they showed this in an animal model. So here you see that initially with no contralateral disease, this FFR here in the circumflex is 0.74, okay, with a left main lesion. And then when they added proximal LAD disease, the number went up to 0.77. So they falsely elevated the FFR and made it negative. The good news is that the disease in the LAD must, however, be very severe. So the LAD disease had to be less than 0.5 for this to actually start to happen. Okay, so very severe LAD disease, you can have false circumflex elevation. And then in JAK interventions in 2015, they then went from theoretical model, animal model, to finally show this also in a human model. And they basically showed the same thing, that if you have very severe disease in the LAD, the circumflex can be falsely positive. I mean, falsely negative, as in the number is higher. Okay, that's an important message. So Dr. B.K. Koo summarizes it very nicely in a little cartoon that he drew up here. So in left main disease, you must measure both sides, okay? If you have very severe disease in the LAD, you may underestimate the left main disease. And I've added a little editorialization here. If the proximal, the lesion must be very severe though. If you measure here in the proximal LAD, you can also underestimate the left main disease because this lesion will cause this number to be higher. And if you measure distally in the LAD, you may overestimate left main disease because this disease also takes into account the disease here. And then don't forget, if you have a CTO in the RCA, you can then overestimate disease on both sides because now this vessel's LAD and circumflex will subtend the entire heart myocardium. And so it makes it look more positive than it truly is if you were to relieve the RCA disease. So what is the techniques in FFR physiological hyperemic left main evaluation? You need to use best technique, calibration, zeroing, drift check, all those things. You must be very careful. Do not use guides with side holes. Make sure in osteo lesions, the guide must be disengaged. And you must use peripheral adenosine, not intracoronary, because you won't need a stable signal to evaluate the effects of all the things. The German Society of Cardiology has an FFR 2017 expert consensus statement, specifically talking about left main. I think that's the only expert consensus statement dealing with left main I've ever seen. They say to measure FFR in both the LAD and circumflex first. If one has relevant stenosis, only take measurements from the other side. So if the LAD also has disease and the circumflex has no disease, only use the circumflex to decide if the left main. If both have stenosis, then they say measurement is not possible. They are very conservative though about this, right? So Dr. Koo from Korea has a slightly different version, and his version is a bit more advanced. He doesn't just stop and say, if both are positive, you should give up and say you cannot do this. He says, do it carefully, assess lesion severity in all vessels, in the left main and in the LAD circumflex and in the RCA. Measure the FFR at the distal end of the most diseased vessel. And here, the important part, he says, if it's significant, do a pullback so that you understand where the step-ups are, right? Measure the FFR then in the least diseased vessel. If this is significant, again, do a pullback. Don't just take dichotomous yes, no answers at the end of the vessel. You must see where the step-up is. If it is non-significant, before you finally say, okay, yeah, this left main is non-significant, always consider the influence of the contralateral severe stenosis as you possibly may be underestimating the disease. So going back to Bill Theron's work, if you have very severe greater than FFR 0.50, you must consider the possibility that you have a false negative. And if significance in both, by using the pullback, you can consider the influences of other stenosis. So it's a bit more advanced compared to the German consensus document. This is a review article by Modi Bian in Neurointervention 2017. And it's pretty much similar to Dr. Ku's recommendations, except that he then also takes into account the PCI part. So once again, they talk about the FFR pullback, and they says that if you start stenting things, always go back and remeasure again, because otherwise you may miss the significance of the left main by revascularizing downstream to the left main, okay? And good advice, if the pullback is very close to positive or negative, there's no reason not to use IVUS to help you also further decide with less than 6 millimeters squared. So just a last slide on IFR in left main evaluation. A lot of people don't talk about IFR. We spend all the time talking about FFR and all the complicated ways to do it. Once again, it's the same thing. You need to do the best technique, calibrate, zero drift check. Do not use guides with side holes. Make sure osteolesions, your guide must be disengaged. Oh, one thing I forgot. Don't forget to use nitroglycerin. Many people forget nitroglycerin. They do the FFR without nitroglycerin. That is not a good idea, okay? You must measure the IFR in both the LAD and circumflex. And if either is negative, this is more simple than FFR. If either is negative, then IFR is negative. And the reason for this statement is because with IFR, theoretically, there's not supposed to be crosstalk. Like there is no tandem lesion, there's no contralateral lesion effect, apparently. It's never been, I've never seen a paper proving this to be true in actual study, but that's the theoretical superiority. And IFR co-registration pullback is one of the strongest tools you can use to show you exactly how all these things interact with each other. So if both are positive, you must evaluate with pullback, ideally with co-registration, to evaluate whether it's the downstream disease that's causing the positivity distally. So to conclude, intracoronary physiology has an important role in intermediate left main evaluation. There's good prospective non-randomized data supporting FFR and a growing body of data supporting IFR threshold before revascularization. You must employ best techniques. You must remember that FFR evaluation is complicated with need to be aware of tandem, contralateral lesion effects, and CTO on measurement. IFR is appealing and is less theoretical interference, but you must use pullback and ideally angiographic co-registration to separate downstream lesions.
Yes.
Okay, thank you very much.
Yes, thank you.
Very much, Professor Wang Li. Presentation. Your lecture is very interesting and helpful. I myself got a lot of information and experience from your presentations.
Oh, thank you.
My colleagues, young colleagues, are very eager to do the lab-based interventions, and sometimes they don't know how to do and when to do. And so I think your lecture will help them a lot, have a lot of confidence and knowledge to do the lab-based intervention now. Thank you very much. Yeah. Okay. Next, we the presentations of Professor Chance from Nanjing First Hospital, Nanjing, China. Though he cannot attend our conference because he busy now. However, we have thank you very much for him because he set up the presentation and the techniques we will do the presentation first. Please. Oh.
Nanjing First Hospital.
Thanks, organizer, for inviting me to present best PCI strategy for left main bifurcation and trifurcation lesion. When, why, and how. I have nothing to disclose. Basically, so far, there are 3 randomized studies compared different standing techniques for this left main bifurcation lesion. On the other hand, there are some RCTs comparing different standing techniques for non-left main bifurcation lesion, particularly from the EBC man and the TCAR Quasi 5 trial to compare the provisional with a different kind of two-step technique. Here, I'd like to say provisional standing technique does not mean one step. It could be shifted to provisional with one step and provisional with a two-step technique. A few years ago, we published our TCAR Quasi 3 and the TCAR Quasi 5 study. From the figure you can see, in TCAR Quasi 3 study, we compared the TCAR Quasi with Coronary standing technique. For distal left man, Medina 111 and Medina 011. True contact perfection. In a similar way, we compared the TCAR Quasi with provisional standing technique in our TCAR Quasi 5 study for distal left man bifurcated lesion. We also provide Thanks, organizer, for inviting me to present the best PCI strategy for left main bifurcation and trifurcation lesion. When, why, and how. I have nothing to disclose. Basically, so far, there are 3 randomized studies compared different standing technique for distal left bifurcation lesion, particularly from the EBC man and the TCAR Quasi 5 trial to compare the provisional with a different kind of two-step technique. Here, I'd like to say provisional standing technique does not mean one step. It could be shifted to provisional with one step and provisional with a two-step technique. A few years ago, we published our TCAR Quasi 3 and the TCAR Quasi 5 study. From the figure you can see, in TCAR Quasi 3 study, we compared the TCAR Quasi with Coronary standing technique for distal left man, Medina 111 and Medina 011, true coronary bifurcated lesion. In a similar way, we compared the TCAR Quasi with provisional standing technique in our TCAR Quasi 5 study for distal left man bifurcated lesion. We also provide 1 to 3 years clinical follow-up. So from our pooled data, TCAR Quasi 2, TCAR Quasi 5, as well as TCAR Quasi 6 trial, of 702 patients were treated using provisional standing technique. From the table, you can see all the increase of side branch lesion length from less than 5 millimeters, between 5 to 10 millimeters, and minimal 10 millimeters. So the rate of cardiac death, target vessel myocardial infarction, target lesion revascularization, target lesion failure, as well as stent thrombosis increased almost 2 times. Last year, Dr. Jira team performed a meta-analysis and identified the cutoff value of side branch lesion length minimal 10 millimeters could predict the clinical worst events. So actually, a few years ago, we studied to establish a definition criteria from 1,150 patients with coronary bifurcated lesion between 2004 and 2006. So this is the study group. After that, we need to test the definition criteria in another validation group consisting of 3,660 patients. So finally, we created the definition criteria for left main distal bifurcated lesion, side branch lesion length 10 mm, and the baseline side branch diameter stenosis minimal 70%. For non-left main, the general requirements for major criteria are side branch lesion length minimal 10 millimeter, and the baseline diameter stenosis minimal 90%. So one major criteria plus any two minor criteria should in the right box, including mild calcification, multiple lesion, bifurcated angle less than 45 or larger than 70, small reference vessel diameter in main vessel lesion length minimal 25 millimeter, as well as thrombus containing lesions. So one major plus two minor criteria, the lesion could be classified by complex coronary bifurcated lesion. After that, we designed and published our definition 2 trial last year. So this is the study flowchart to show the randomization and the grouping of a total of 660 patients with complex coronary bifurcated lesions stratified by definition criteria. It was conducted in 49 international centers. The primary endpoint was 1 year tight lesion failure, TLF. Safety endpoint was stent thrombosis. Secondary endpoints included mortality, cardiovascular death, incident stenosis, myocardial infarction, TLR, and TVR. At 1 year follow-up, in the provisional group, the TLR and the tight vessel myocardial infarction rates were 5.5% and 7.1% respectively, significantly higher than 2.4% and 3% in the two-stent group, leading to very high 1 year TLF rates, 11.4% compared to only 6.1%. In the two-stent group, more than 80% of the lesions were treated using DK quash. So we could propose that DK quash is superior to provisional stenting technique for real complex coronary bifurcated lesions. However, what's the reason for high rate of tight vessel myocardial infarction, which was driven mainly by periprocedural myocardial infarction of the provisional stenting technique? So we designed and completed another OCT bifurcation trial. From the figure, you can see basically all the patients who received provisional stenting technique were classified by lesion length inside branch. So for patients with long side branch lesion length, the presence of vulnerable plaque in the main vessel was a strong predictor of periprocedural myocardial infarction. From figure, you can see in patients with long side branch lesion and vulnerable plaque in the main vessel. So the 1 year tight vessel myocardial infarction was 9.7% compared to only 5.9% among patients with side branch lesion length without vulnerable plaque in the main vessel. So it means that the presence of vulnerable plaque in the main vessel could be the major concern before the decision of using provisional stenting technique. Next, we need to identify the correlation of periprocedural myocardial infarction with the mortality of the bifurcated stenting. From our full randomized trial, finally, of 1,300 patients were included in the analysis. Of them, 56 patients had periprocedural myocardial infarction of the bifurcated stenting, compared to 1,244 patients without periprocedural myocardial infarction. This is a figure showing the difference in the incidence of periprocedural myocardial infarction according to first UDMI, ischemia, SCAI, syntax, and Excel criteria. So the higher rate of periprocedural myocardial infarction according to first UDMI and ischemia definition. Also, there was a significant difference in terms of the prevalence of all-cause death and cardiac death based on different criteria for the definition of periprocedural myocardial infarction. So the table shows the correlation of periprocedural myocardial infarction with any death after bifurcation stenting. So basically, first UDMI definition and ischemia definition could establish the relationship of purposive myocardial infarction with any cause death. So this table only showed the adjusted analysis of syntax criteria, SCAI criteria, and Excel definition define purposive myocardial infarction with any death. In 1 year follow-up, there was no correlation between purposive myocardial infarction and any death. But after 1 year, by the end of follow-up, varied from 6.6 years, there was a very, very strong correlation between PMI and any death, according to these three definitions. So the table indicated the significance of purposive myocardial infarction with long-term clinical outcome in patient with coronary bifurcation lesion after stenting treatment. Also, clinically, we need to identify a simple biomarker to predict the long-term clinical outcome. The table showed all the increase of CKB from less than 1 time increase, between 1 and 3 times increase, between 3 and 5 times increase, and 2 minimal 5 times increase. So the event rate of mortality increased significantly, particularly when CKB increased minimal 5 times. So the correlation of CKB and mortality of the bifurcation stenting was enhanced significantly. Again, EBCMA was published recently, and many colleagues focus on the comparison of EBCMA and the DK-Quashi-5, because our previous DK-Quashi-3 study compared the DK-Quashi with culotte stenting technique. So here we focus on the comparison of EBCMA and the DK-Quashi-5 trial. So from table you can see more simple bifurcation lesion included in the EBCMA. Even these two trials compared a provisional stenting technique with systematic two-stent technique for distal left main bifurcation lesion. For example, from the inclusion criteria in EBCMA, syntax score less than 32, MI older than 72 hours, no CTO in any vessels. But in contrast, in DK-Quashi-5, MI older than 24 hours, and also OCT in any vessel after successfully recanalized, the patient could be included. Also, according to the protocol in the EBCMA, so the two-stent technique included different kind of two-stent approach, including TTAP, culotte, or DK-Quashi. But in our DK-Quashi-5, only DK-Quashi was allowed to use. Both studies are designed as a superiority study. But from this table, you can see the assumption of the EBCMA was a 25% of 1 year primary endpoint in the two-stent group compared to only 14% in the provisional group. But in our DK-Quashi-5 study, only 7% of assumpted 1 year primary endpoint in the DK-Quashi group compared to 14% in the provisional group. Finally, syntax score was 23 in the EBCMA, significantly lower than 31 in our DK-Quashi-5 study. Also, in our DK-Quashi-5 study, there was a very strict qualification for participants in each center. For example, so the primary operator should have minimum 300 Pci cases 1 year with minimum 20 left main Pci experience. Also in EBCMA, side branch lesion length was only 7 millimeters, significantly shorter than 16 millimeters in our DK-Quashi-5 study. Also in our DK-Quashi-5 study, almost 32% of lesions are classified by complex bifurcation lesions, but it was not studied in the EBCMA trial. So at 1 year follow-up, so the crossover rate from provisional to two-stent was 22% in the EBC man and 41% in our DCAT Quasi 5 study, which reflected the real high complexity of bifurcated lesion in DCAT Quasi 5 study. I-was use was very similar between two trials. At 1 year follow-up, the actual rate of primary endpoint in the two-stent group was 17.7% compared to 14.7% in the provisional group without significant difference. But in our DCAT Quasi 5 study, so we showed a very similar rate of 1 year primary endpoint of the provisional stenting technique to EBC main trial. But in DCAT Quasi group, the 1 year primary endpoint it was only 5%, significantly different to provisional group. Also, DCAT Quasi stenting showed a very low rate of cardiac death and target vessel myocardial infarction of the DCAT Quasi technique compared to provisional stenting approach. So far, there are some criticism on EBC main trial. Firstly, it was a simple rarity study with overall neutral results. From this result, we could not see one node inferior to another. We could not see provisional is non-inferior to systematic two-stent technique. Secondly, they assumed the rates of the primary endpoint were 25% in the upfront two-stent group and only 14% in the provisional group. So the gap was 11%, but actually the rate of 1 year primary endpoint was 17.7% of the two-stent group. So it means the study design increased the bias and the risk of type 2 errors. Finally, only 85% of patients had appropriate cardiac enzyme measurement, which may have implications for the assessment of peri-procedural myocardial function, a very important component of the primary endpoint. Also, because most of lesion in the EBC main trial could be stratified by a simple bifurcated lesion, so the risk of the EBC main trial was to stimulate intervention cardiologists to pursue the stepwise provisional single stent strategy in the majority of patients present with complex distal left main bifurcated lesions. In fact, for distal left main bifurcated lesion, there may not be side branch in the sense of clinical unimportance when treating left main disease, because stent flex also supplies a large amount of myocardial. So here, finally, I'd like to share the latest version of DCAT Quasi, a cartoon to show how to do DCAT Quasi step by step. Exactly immediately after stenting side branch, we need to complete the Quasi using appropriate size of NC balloon to make sure side stent struts opposed to the main vessel wall. After that, we always address the importance of rewiring from the proximal cell. Before each kissing balloon inflation, I always recommend to alternatively dilate side branch to main vessel and followed by simultaneous kissing inflation in both vessels. Never forget final port technique after each kissing balloon inflation. Also, please don't forget the importance of intravascular imaging for bifurcated lesion, particularly for left main lesion. Thanks for your attention.
Yeah, thank you. We presentation from Dr. Sound from the Nanking University. And we are very grateful not to discuss with Dr. Sound. Now we have moved to the discussion. I would like any the comment or any question from the audience to Professor Ko or the Professor Lee. I would like to ask you, Dr. Professor Ko, one question about us. Is there any difference the revascularization between the you present the MACE and DAS between the two strategy for the acute coronary syndrome and chronic syndrome? But I would like to ask you the different revascularization rate after long term, 1 year, 2 year, 3 year after we intervention of left main. Yes. In the acute and the CSAT, is it different or not? Yes. Professor Ko, yeah.
Yeah, I don't have the data offhand, but
Yeah.
the overall revascularization rate is not very high. If you look at the stable or chronic ischemic heart disease trials that has been shown, it's only about like 7% or more. So it's not a very high revascularization rate. And patients who have acute coronary syndromes, particularly with STEMI, they have a lot of increased mortality outcomes. So I think it's more of the poor LV function impairment that leads to adverse outcomes rather than repeat revascularization. It's probably, I would say, maybe less than 10%. Not sure whether Kwan Lee, you have
we don't have revascularization rate data in left main unprotected post ACS cardiogenic shock. As you pointed out, a lot of the long-term mortality is related to long-term heart failure issues. That's a very difficult sub-cohort of patients to study. So yeah, we don't have that data. I suspect the people that survive, because you notice that the BCIS divided it into 3 pre-specified curve separation groups. The ones that die early are weeded out, the ones that then die. So by the time you get to 1 year survival, probably your revascularization is the same as other people, because all the ones that were not going to be same have died before they got there.
Maybe we, yes, maybe the evaluation physiologist evaluation before we do in the ACS. When we do in the ACS, we beside the intervention, we don't measure the FR or physiologist evaluation in this patient. Maybe
you can't do it because the FFR is not in ACS with downstream. In the left main, you're going to have small amounts of myocardial infarction downstream to possibly both vessels. So FFR will not be valid in the infarct-related artery. But for left main disease, both vessels are the infarct-related artery. So you probably can't use hyperemic techniques. Maybe you can use IFR, but I think the one thing that's not well addressed, everybody is having the discussion about DK crash versus provisional. In the setting of ACS and left main, I think you need to do the technique that gets the job done the fastest. You don't have time to really sit there. If you are not using Impella or ECMO, where the patient can become very stable and then you can take all your time IVASing and doing whatever, you really need to just work very, very fast to get the patient out of trouble first. And I think nobody is ever going to do a randomized trial of provisional versus 2-stent technique in acute coronary syndrome because it's not possible, right? You just need to work quickly. But probably a provisional technique with a tap bailout or a reverse culotte or a culotte bailout is probably the smartest technique to use in crashing cardiogenic shock left main patient. You just cannot spend the time.
Yeah, thank you. Yes, Dr. Ben.
I would like to share some of my experience in my cath lab. Recently, I don't know why, in my cath lab, a lot of patients very young, about 40 years old. and then he has the occlusions of the left vein with the cardiogenic shock, very severe. Though we use the balloon pump to help them, and then do the PCI, but after about 2 or 3 days, though we do the revascularization rather good, but the patient still die. Do you have any comment or experience how to do in this case?
Yeah, maybe I can take the question first, and I'm sure Conley, because he's got a lot of experience with the circulatory support devices, which we don't have in Singapore, unfortunately, or at least in our center. What we do is still doing intra-aortic balloon pump like what you have been doing. But we know from the IABP shock trial that is really not effective in cardiogenic shock, and it's been like, you know, a class 3 kind of recommendation now from ESC. But I mean, that's the only one we have. And I actually look at the data from the BCIS registry. Although it's not significant when they use the IBP, it was like very close to significant. So there could be some benefit. And I think that's the only device that we have to support the patients and make us feel better during the procedure. Of course, if you have the important circulatory support devices like ECMO, which I think you should have, then you could use that to support the patient, which I shared in one of my case. That can help tide the patient over for a couple of days so that the LV can somehow have some recovery, particularly in young patients. And then we might need to bridge them to long-term LVAD support or heart transplant if you have that facility. But I think with the Impella and other better support devices like tandem heart, maybe it would be much better. So would like Kwan Lee to give us some comments because he's got experience in US on this.
Yeah, so I think in the US, you know, especially with our large healthcare cardiogenic shock network system data, like from the Detroit group, from the Innova group, etc. What we have seen overall is that over the years, the mortality in cardiogenic shock has actually started to improve in ACS. You know, whether it's a direct result of the very heavy use of Impella, ECMO, etc., that is harder to say, you know, but I think for survival of patients with left main ACS and cardiogenic shock, revascularization is only the first step, right? Your entire network of downstream support in the next week, because these patients often don't get better instantaneously. You still have to look after them in the ward, and then you have to look at your systems of care in your CV ICU. Are you putting a SWAN in? We in the US are very aggressive with putting SWAN GANS catheters in and using the numbers, because you can always put a SWAN catheter in, but if you don't continuously respond to the data from the pulmonary artery catheter, you're not going to get anywhere, right? If you just put the balloon pump and put the SWAN, and then the nurse doesn't call you all night long and just keeps titrating up the adrenaline higher and higher and higher, the patient is not going to survive, you know? So you have to have very clean cutoff. You have to have very good monitoring systems of response, and it has to be 24/7. Many CCUs in the United States have started to go from having nurses only and then the doctors at home to having senior doctors in-house all the time. I'm sure in Asia it's the same. But you have to be there, and you need to be ready to always respond and take them for the next level of care. So you put the IABP first, it starts to work, it stops working. Then you need to be able to take them back and do, you know, Impella, ECMO, and all the different things. And the one aspect that's often neglected, even with Impella, is the right ventricle. If the right ventricle starts to fail, you can do everything you want to the left ventricle, you are also not going to succeed. So that's why here we have bipella, right? Impella left side or right, or Impella RP. Some of our patients get both. And, once you send them back, once you start putting these large bore devices in, the next problem that you have to deal with is bleeding from the groin from large bore access, 14 French access, and so you have to also become very good at dealing with all these things. So it's much more complicated, unfortunately, than just stenting the patient up front. And that's why I think overall, in the absence of these well-organized systems, you still, mortality in cardiogenic shock in ACS for most places really has not improved very much over the years, right? You need the whole package, but at the same time, the whole package is very, very, very expensive.
Yeah.
So what do you do there? At some point, you have to decide where you spend your money.
A lot of money to save one people. Yes,
yeah,
we have. Yeah. Now we have. Yeah,
we have one patient the other day. Young patient.
In Vietnam, do you have ECMO? Do you all use ECMO at all?
ECMO. Yeah, ECMO.
Yeah.
Yeah, we have ECMO in my.
ECMO in my cath lab.
Yeah, we have.
Because now they have this cardio help that you can.
In Vietnam now. In Vietnam now we have in the Hanoi, and in Ho Chi Minh City and Hue we had ECMO. Yeah. We started only the 30, about not so many cases until now. In Bela we don't have. Yes. So on the case, when we do the PCI with the acute coronary syndrome with the shock, we use the ECMO. Some case we use with the IBP. Yes. Like the yes. Very it's very regretful not Dr. Professor South Lin Chen from the Nanking to join with us for discussion, because he very experienced in the PCI of the left man, especially for the K-class bifurcation technique. Yes, but it is not enough time for my session. So I invite Professor Ko to wrap up and conclude this session. Please, Professor Ko, please. Yes.
Thank you, Professor Nia. It's my pleasure to conclude this session on left main PCI. It's really a wonderful session that I participated in together with Quan Lee from US, a good friend of ours in Asia, as well as from the recorded session of Professor Cheng Xiaolian. He's a well-known, world-famous left main stent implanter. And we heard quite a lot of new knowledge that, for example, for my presentation, the patients with have ACS, particularly in cardiogenic shock, really is a different animal compared to stable IHT patients with left main. So you need to be very careful when you're dealing with this kind of patients. And you should probably get experienced doctors to do the left main PCI in the acute setting. Have better outcomes. Dr. Quan Lee's talk was very illuminating. I think he in the US they still use the cutoff of IVUS of 6 mm square, although in Asia we tend to use the Korean 4.8 mm as a cutoff, but using FFR and IFR, as he has demonstrated very effectively, gives us a much better assessment about the physiological outcomes to intervene in left main, bearing in mind of false negatives if you have very tight lesions in the contralateral vessel, as he has shown to us. And the tips and tricks of how to do the FFR and IFR measurements. And lastly, with Professor Cheng Xiaolian's very nice lecture on bifurcational stenting, comparing the DK crush with positional stenting. Looks like if you can do a much better DK crush in complex left main bifurcation lesions, then that should be how it should be done. So with that, I would like to thank Professor Nia and Dr. Ho, all the other panelists for this nice program. And thank you, and see you soon, and hope that
So, good morning, everybody, and maybe good evening for the speaker in the US. Yeah, I'm sorry because I have to wear a mask like this because I still have a COVID patient in my hospital now. Dear colleagues, today we have a session about the management of chronic coronary syndrome. We should do PCI or CPC for our patient, or we should do optimal medical therapy for them. We have two landmark trials, Courage trial in 2007 and Ischemia trial in 2019. I think it still have a controversy about the way to manage CCS patient. So today we will discuss on this session, and I am Professor Trung Quang Bình from University Medical Center in Ho Chi Minh City, and my co-chair, Associate Professor Gregory Partners, and we have two panelists, Dr. Nguyễn Cù Lợi and Dr. Bùi Long. And first of all, I would like to invite Dr. Fahim Haider Jafaris. He is interventional cardiologist of Tan Tock Seng Hospital in Singapore. He will give us the topic revascularization or medical therapy. Do we have a courage to unplug ischemia? Dr. Jafari, please. Em ơi, cho phát cái bài của bác sĩ Jafari đi em. Em ơi, thư ký ơi. Oh, Dr. Lợi, do you have
thank you very much for the invitation to give this talk. I'm really grateful for the opportunity. In the next 15 minutes, my job is to talk about revascularization or medical therapy and talk about do we have the courage to embrace ischemia. I don't have any conflicts of interest related to this talk. By training, I'm an interventional cardiologist, but I'm also a nuclear and CT cardiologist. I do a lot of imaging. And so with these multiple hats, I'm hoping that I'll be able to give you a more balanced view of the subject. Now, the ischemia paradigm has had a great run, and for decades, we've been using stress testing to guide treatment decisions, particularly when it comes to invasive management. And of course, the ischemia paradigm goes back to the 1970s when the clear studies showed that when you have a normal or mildly abnormal stress test in green compared to a significantly abnormal stress test, the survival is significantly worse if you have an abnormal stress test. And this was sort of cemented by the Akamovich group in the early 2000s, where they were able to show a relationship between ischemic burden and benefit of revascularization. To the point that at an inflection point of about 10% ischemic burden, the curves of medical therapy in red and revascularization in green start to diverge. And, at about 20% of ischemic burden, there's a marked improvement in survival when you revascularize compared to medical therapy. And so this led to the sort of the teaching that ischemia is bad and we need to fix it. Of course, there were some limitations to these studies, starting with the fact that these were based on observational non-randomized data. And of course, that is confounded by frailty, comorbidities, and biases. And this was largely single-center data and pertaining to an older era when medical therapy was neither good or standardized. And at the same time, PCI was also in its early stage of evolution. And so when randomized trials were conducted, they started to show a slightly different picture where when you looked at death or non-fatal MI, really no difference between medical therapy or PCI. And the only difference was largely urgent revascularization and to some extent symptoms in these randomized trials. And I draw your attention to the Courage trial, which we talk about the most. And that was one of the first trials that showed this, where they took patients with stable coronary artery disease, put them through an angiogram, and then randomized them to either medical therapy with PCI or just medical therapy alone. And lo and behold, no difference in death or MI or hospitalization for ACS between PCI with medical therapy or just medical therapy alone. There was some benefit in symptoms in the early phase of the trial at 1 year, but longer term, there was no difference in symptoms either, whether you treated them medically or with PCI. And going as far out as 15 years, again, no difference in hard endpoints between PCI or medical therapy for stable ischemic heart disease. Even in the Fame 2 trial, which didn't look at ischemia, but looked at a surrogate of ischemia with an abnormal FFR, no difference in death and some difference or a trend in difference towards reduction in MI if you treat it invasively. Of course, there's some caveats to the COURAGE trial, starting with the fact that the COURAGE trial enrolled patients after angiography, and that, of course, leads to a lot of bias because the high risk and really complex disease was probably excluded. And of course, the COURAGE trial actively excluded patients with, significantly adverse features like low EF, really severe angina, and very severe ischemia. If you look at it, most of the patients in the COURAGE trial had a low ischemic burden. And of course, the COURAGE trial used bare metal stents, which would then mean that the symptomatic benefit would not be durable. And if you look at the COURAGE trial itself, most patients had either single or double vessel disease, so relatively simpler disease. And only a minority had proximal LAD disease, which we know tends to be a bit prognostic. So with these caveats in mind, the ischemia trial was designed to answer the question that when you have patients with moderate or severe ischemia and you randomize them without knowing the angiogram, what happens to them if you randomize them to invasive therapy with optimal medical therapy or just conservative optimal medical therapy alone. They did a blinded CT on patients to make sure that these patients didn't have left main disease or didn't have no coronary artery disease, and then randomized them with a median follow-up of 3.2 years. It's important to look at the exclusion criteria of the ischemia trial. They excluded, again, relatively higher risk patients with unacceptable angina despite medical therapy, which is reasonable, but patients with low EF were excluded. Patients with a recent ACS or recent PCR CABG were excluded. And those with left main disease, as identified on the blinded CT, were also excluded from the trial. To their credit, the ischemia trial included patients with quite a bit of ischemia. So 80% had either moderate or severe ischemia, leaning more towards the moderate side, but nonetheless significant ischemia. And the LAD involvement was in almost 90% of patients. When the results were looked at, it's interesting that for the primary endpoint of death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest, the invasive arm in red and the conservative arm in blue over a median follow-up of 3.2 years, no difference in the primary endpoint. When you look at the secondary endpoint of cardiovascular death or MI, again, no difference between the two arms. Now, if you notice that in the earlier months, there was a suggestion that there was more MI in the invasive arm, and that was driven largely by the periprocedural MI. And in the later years, there was reduction in spontaneous MI in the invasive arm. But overall, again, no difference. And it didn't matter what subgroup you looked at. If you looked at the degree of ischemia, no difference. If you looked at the severity of coronary artery disease, it didn't matter whether you subjected them to revascularization or medical therapy, and certainly in the LAD group, no difference. What about symptoms? Well, the trial suggested that there was a durable benefit or reduction in angina going from month 3 to 12 to 36. Across the board, a significant reduction in symptoms or reduction in angina. However, that benefit was limited only in those with significant angina to begin with. And that was only 21% of the subject or 22% of the subject. And if you look at it more closely, only a small fraction, less than a quarter, had daily or weekly angina, whereas the rest had either no angina or monthly angina. And again, over 1/3 had no angina to begin with. So only in those who had significant angina was there a reduction in symptoms. Some interesting exploratory analysis have been published of this from the ischemia trial, including looking at those with heart failure, completeness of revascularization, and the severity of angina. And as you may recall, class 3 or 4 heart failure and an EF less than 35% was excluded from the trial, but there were about 400 patients with a history of heart failure, class 1 or 2, and or an EF that was between 35 and 45. And there was a suggestion that in this group of patients with heart failure or modestly reduced EF, there was a benefit if if they were treated invasively versus conservatively. But in those with a normal EF or no heart failure, there was no difference. They also looked at completeness of revascularization, and this was sort of a exploratory analysis where if you looked at patients who achieved anatomic or functional revascularization versus those who didn't, there was a suggestion that the invasive arm did better compared to the conservative arm. But this is a really unfair comparison because none of this is randomized. You're just looking at those who achieved complete revascularization versus who didn't. And of course, some folks were harshly critical of this analysis because, again, it is really none of this is randomized. And so one has to take this with a pinch of salt. So in ischemia, then, there was an initial invasive strategy had no effect on the primary endpoint of death, MI, hospitalization, or cardiac arrest. There was no effect on the secondary endpoint of death or MI. There was no effect on mortality. There was an increase in early periprocedural MI balanced by a reduction in later spontaneous MI. There was possibly some benefit in those with heart failure or a lower EF of 35 to 45%, and there was possibly some benefit if you achieve complete revascularization. But as I said, these are hypothesis generating at best. It didn't matter how much ischemia or how extensive the coronary artery disease was, and there was a durable and robust reduction in angina, but only in those with significant symptoms to begin with. And one also always has to raise the question of whether this is real or a placebo effect. And why do I say that? Because I draw your attention to the Orbiter trial that was published a few years prior to ischemia, where they looked at patients with stable coronary artery disease, randomized them to an actual PCI versus a sham PCI. And at the end of the day, there was no difference between those who underwent actual PCI versus sham PCI. Both accrued a benefit. So even sham PCI improved their symptoms. Of course, there's some caveats to the ischemia trial, starting with the fact that its applicability to the real world. They excluded a lot of patients, as we've already talked about. And if you look at the NCDR database, there are about 1 million patients. Only a third of the patients would be, quote, ischemia-like. And we know from other data that ischemia-like patients have lower death in blue, lower bleeding, or requirement for dialysis compared to those who are non-ischemia-like. So the ischemia trial sort of subselects out a low-risk population. And we know from the selection that the selection was weighed towards the less severe patients. So about a third had no angina. There were more moderate than severe ischemia in the cohort, and more than 10% had mild ischemia on objective testing. But you also have to acknowledge some of the strengths of the trial. Of course, there was large numbers. Randomization was before angiography. There was core lab interpretation of ischemia, and it included a lot of patients who we previously unequivocally thought needed PCI, and those with moderate to severe ischemia, those with LAD or multivessel disease. Of course, there was rigorous adjudication of events, and medical therapy was as good as it could be, and so was PCI. Revascularization was as good as it could be, and follow-up was in more than 90% of the patients. So how do we then put it all together? How do we put ischemia and courage together? And I'd like to draw your attention to sort of a bunch of patients with chest pain in your practice. And when you take a history, you will probably find some of them with severe or accelerating symptoms who will immediately send to the cath lab. There's no question about that. That's easy. But for the rest of them, you would then consider some sort of stress testing. And when you stress test them, sure enough, you will find some who have either normal or mild ischemia, and some with a really, really abnormal stressors. I'm talking about their blood pressure tanking when they exercise, or their ST segments going up, that kind of stuff. And these would appropriately be sent to medical therapy or the cath lab. And then you're left with the rest, those with moderate to severe ischemia, who before the ischemia trial would then be subject to cardiac catheterization because that was the standard of care. After ischemia trial, I think you have equipoise between medical therapy and invasive therapy. And you could then discuss with the patient the option of either going to the cath lab or ruling out left main disease non-invasively. And some patients would say, no, I don't want any ambiguity, and they would want to go to the cath lab, and that's shared decision-making. But for the rest, you would then do a CT to rule out left main disease. And that's important because you get patients like this, like we had recently in our practice, severe infralateral ischemia, got lost to follow-up initially because of COVID, came back with an ACS and had severe left main disease. And you don't want to miss these. And so when you do, let's say, a CT for left main disease, sure enough, there will be some who have left main, who you would then send to the cath lab. But the rest can then be treated medically, at least initially. Remember, we're talking about initial medical therapy. And after medical therapy, sure enough, some will flunk it, and you will then send them to the cath lab. But then the rest can, if you see, will actually do very well with medical therapy. And so then the question then arises that if ischemia is bad, why is fixing not good? And that brings us to the issue that in stable coronary artery disease, ischemia is really a marker of the primary process, which is atherosclerosis. It's a surrogate marker of atherosclerosis. And, the disease is atherosclerosis, and ischemia is a consequence. And the driver of prognosis is actually the atherosclerosis. And so when you treat the tight spot, it does relieve the symptoms, but doesn't change the extensive atherosclerosis. And we can see this from a recent analysis of the ischemia trial, where when you look at patients with degrees of ischemia, mild, moderate, or severe, there's actually, the severe ischemic burden was not associated with death. And severe ischemic burden was only modestly associated with MI. But on the other hand, when you look at disease burden, and that's sort of defined here by the modified Duke prognostic score, where this is high disease burden, 3-vessel disease or 2-vessel disease, and this is low disease burden. As the disease burden goes up, you have both a strong association with death as well as MI. And so coronary artery disease severity, but not ischemia severity, was predictive of myocardial infarction. But importantly, it didn't matter how much ischemia you had, and it didn't matter what the extent of coronary artery disease was. Revascularization did not alter prognosis because, again, revascularization does not treat the primary process, which is atherosclerosis. It's medical therapy that does that. Now, in ACS, unlike stable CAD, the biology is different. You're looking at a biology of a ruptured plaque, and a ruptured plaque can progress to occlusive MI, and treating that spot actually potentially aborts an MI at that spot. And so that's why there is a prognostic benefit. So it's a different pathobiology. So ladies and gentlemen, if I was to conclude, the ischemia paradigm in stable coronary disease has changed. Now, detection of ischemia in stable CAD still remains important because it helps initiate appropriate medical treatment. On the other hand, treatment of ischemia in stable disease by revascularization provides durable symptomatic benefit in those with a lot of angina, but provides no clear prognostic benefit, with the caveats that the highest risk ischemia was excluded, left main disease was excluded, and low EF was excluded. And I think in 2021, medical therapy for ischemia is okay as an initial step if prognosis is the concern, with the understanding that these are the caveats: no severe symptoms, no ACS, no heart failure, no low EF. Also in 2021, revascularization for ischemia is okay as an initial step if symptoms are compelling. So the caveat is that it won't affect prognosis, but remember, it's okay to make patients feel better. And I think we should have the courage to embrace ischemia, and we should be comfortable treating ischemia medically. But at the same time, we should not be discouraged to stent to make a patient feel good. And you need to have that honest discussion with the patient and the family. And that honest discussion is that, look, PCI or revascularization versus medical therapy, there's not better or worse, there's just different. And revascularization may make you feel better, but it won't make you live longer. And it's important to understand that even if you get revascularized, you will still have to take tablets or medical therapy. And finally, in 2021, revascularization should be the initial approach for patients with acute coronary syndromes. One final thought that is important to walk away with, that in both ischemia and courage trials, almost 20%, there was an almost 20% cumulative event rate at 5 years, despite the best of our therapies. So we still have a long, long way to go in adequately treating these patients. Ladies and gentlemen, thank you very much. I'll be happy to answer any questions that may be.
Thank you, Dr. Fahim Jafari. I think it's a very interesting presentation. And we have a 5 minute, still have a 5 minutes for discussion, but I think that we will share 5 minutes for the part of discussion at after 3 presentation. And now we move to the second presentation. I would like to invite Professor Faisal Latif. He's
0.45 as compared to controls, which was abnormal, but it was the average was 0.58. And all CTO patients demonstrated an ischemic FFR. So all of the patients in this study were ischemic, despite that they have had a chronic total occlusion, that is their coronary artery is occluded for a long time, and still they have significant ischemia. It is not dead. Long-term outcomes after Cto Pci with Everolimus Eluding Stents. This study basically looked at how these newer stents, the newer generation stents, do in chronic total occlusions. They looked at about 250 consecutive patients, looked at 1 year major adverse cardiovascular events. The procedural success was 96%. And they found that compared with a pre-specified performance goal derived from 6 prior trials where they had used drug-eluting stents to treat chronic total occlusions, where 1 year major adverse event rate was 24%, with the use of Everolimus Eluding Stents, it was the 1 year adverse event rate was only 8.2%. So these stents have improved the 1 year outcomes in patients undergoing PCI with drug-eluting stents for chronic total occlusions. Also, the target lesion revascularization at 1 year was only 6%, which is quite good. So use of Everolimus Eluding stents should be strongly considered in patients who have chronic total occlusions. Moving on to how to revascularize. So I have so far talked about when to revascularize. I'll move on to how to revascularize SVGs and maybe CTOs a little bit. So what are the issues in SVG interventions? We know that there could be discal embolization, there could be no reflow, support issues can be there. Then I'm going to actually show a case where there is a retrograde segment from which needs PCI. And there is aneurysms, tortuosities, all of these issues come up. So first of all, distal embolization, how do we prevent that? So the important factor that is very underutilized is an embolic protection device. The guidelines from American College of Cardiology from 2015, they say that it's a class 1 indication to use embolic protection devices, these filter devices in SVGs. However, report from National Cardiovascular Data Registry, the Cath PCI registry, the use was only 10% back in 2010. So it is important to know that it is very underutilized. The other important complication that can happen is no reflow, and that is mainly because of plugging of microvasculature that can cause slow or no reflow. What predicts that? Presence of thrombus, acute coronary syndromes, degenerated vein grafts, or ulceration of the lesion. And if you're using a filter during an intervention of SVG, and if it is full, aspiration thrombectomy should be used before removing the filter. How do we treat no reflow? Nicardipine is very effective, but it is expensive. Nitroprusside works well. You just have to be careful about renal failure. And you can use nitroprusside and adenosine together, but just have to be careful that this can cause hypotension and bradycardia. But these medicines can be used in case of no reflow. Then how about, direct stenting? That is putting in a stent without using adjunctive angioplasty at all. Because if you imagine when you inflate a balloon in the SVG, there could be distal embolization of clot and tissue embolizing distally. So in this study, we looked at 575 patients from the DIVA randomized control trial between drug-eluting stents and bare metal stents from DIVA study for SVGs. 32% of patients underwent PCI with direct. Hello, my name is Faisal Latif. I am a clinical associate professor of medicine at University of Oklahoma, and I am affiliated with the American College of Cardiology as well as Society of Cardiovascular Angiography and Intervention. I have been tasked to talk about revascularization for asymptomatic chronic total occlusion of coronary arteries, or SVG, saphenous vein graft occlusion, when and how. Here are my disclosures. So when you think about an asymptomatic patient, this is a difficult patient population because your patient is asymptomatic. When would you do a PCI or place a stent in their heart? So I took some assistance from the European Society of Cardiology guidelines from 2018, which kind of breaks down revascularization of coronary arteries into two major aspects. One is to do it for prognosis, that is basically to improve the life expectancy of the patients, or to do it for symptoms. So for prognosis, they say that if the left main disease is more than 50%, there is proximal LAD disease, 2 or 3 vessel disease, LVEF less than 35%. So basically, if you use those kind of criteria, maybe we can talk further about when to consider PCI in patients who are asymptomatic and when to fix their chronic total occlusion with stents. So I think for this, it is important to understand the natural history of the saphenous vein grafts. Back in 1962, Dr. Sabiston from Johns Hopkins University was the first physician to use a saphenous vein graft to tie it to the right coronary artery. Followed by him was Dr. René Favaloro, who standardized the surgical technique of using saphenous vein grafts and is called the father of coronary artery bypass grafting. And to this day, the saphenous vein grafts remain the most commonly used conduits in CABG, even though we know that arterial conduits like LIMA, right internal memory artery, gastroepiploic artery, they work better than veins, but veins are easy to harvest and still are the most commonly used conduits. What's the problem with saphenous vein grafts? The problem is they don't work as well. About 12% of the saphenous vein grafts are occluded even before the patient goes home after a bypass surgery. Up to 25% of them are failing at 1 year, and then up to half of them could be occluded after 10 years of bypass surgery. These days, about the data shows that about 13% of patients require repeat revascularization within 10 years after CABG, but 18% of all PCIs are performed in patients who have had bypass surgery in the past, and about 6% of them are actually performed on the SVGs. Now, as you can see, this is older data. This is from 2004. We do not have a lot of current data, and it may be that SVG survival has even worsened in the last 10 to 15 years. So here is a graphic from Dr. Xenogiannis and Dr. Berlakis' paper from Circulation this year that talks about the natural history, that after implantation of SVGs, actually they start developing early remodeling. And then in the first 4 to 5 years, they start developing some stenosis. Then at more than 5 years, after more than 5 years are passed, the stenosis started worsening, and then it leads to total occlusion. The natural history study of SVGs so far shows that once an SVG fails, it tends to continue to fail after that, and the chance of its survival over the ensuing years is pretty low. I also looked up what guidelines do we have to try to revascularize in patients' SVGs who are asymptomatic. So I looked at the appropriate use criteria from which is the latest version is from 2017, published in JACC as well as the circulation journals. It basically showed that if patients are asymptomatic, then if I would like to focus here on this part of the slide, which is that if there are low-risk findings on non-invasive testing, that is their stress test is low-risk finding, or if their ejection fraction is more than 35%, then it is rarely appropriate to do PCI. And also if there is a bypass graft that is supplying only one territory of the heart, then it is rare it is rarely appropriate to do PCI. But if they have intermediate or high-risk findings on a stress test, or the FFR beyond the SVG in the native coronary artery is less than 0.8, then it may be appropriate to do PCI. Now, if a bypass graft is supplying two territories, that is, there is a bypass graft and there is a Y graft, it's supplying two coronary arteries downstream, then it is more appropriate to do PCI on those patients. Now, if the SVG that we are looking at is supplying the LAD territory or the anterior wall, then it is much more liberal that it allows us to do PCI in asymptomatic patients, even if the stress test is low risk. And if it is high risk, then of course it is more appropriate to perform PCI, even if the patients are asymptomatic. So essentially, there are two categories of patients who have lesions in vein grafts after bypass surgery. Those who have LAD territory being supplied, the threshold for revascularization of those patients is lower, so you have more liberty to go ahead and fix them. If there is a non-LAD territory, then there is less liberty to fix them if the patient is asymptomatic. If the patient is symptomatic or has high-risk findings on the stress test, then I think this is much more appropriate to perform PCI in those bypass grafts. How about FFR? FFR, as we know, has evolved a lot in the native coronary arteries in the last 20 to 25 years. There is a lot of data, including prognostic data, that if FFR is abnormal, then PCI of those coronary arteries is very appropriate. However, when you put a bypass graft to a SVG, that is, an SVG is implanted to a native coronary artery, then it is much more different, and I'll explain in the next slide why, and there is very little data to support that. So this small study is from 2008, which looked at 10 SVG lesions in 10 male patients who had an abnormal myocardial perfusion scan. All SVGs had a diameter stenosis of more than 50%, and 30% had a diameter stenosis of greater than 70%. FFR was abnormal only in 30% of the patients. This was a study correlating the FFR with the myocardial perfusion scan findings, and they found that there is good specificity and negative predictive value compared to stress test. So FFR can be useful. However, it is important to know that this is much less studied than the native coronary arteries. And the problem is that when there is a stenosis in the vein graft and you put the FFR wire down into the native artery, there could be competing flow from the native coronary artery. There is presence of collaterals from long-standing native coronary occlusion and microvascular abnormalities, which may not be as they are in a heart that has not had bypass surgery. However, the appropriate use criteria document says that despite these factors, the theory of the FFR, which is dependent on the microcirculation, should apply equally to both a lesion in the SVG feeding a normal myocardial bed and a lesion in the native coronary artery. Therefore, if you use it carefully, an FFR could be used in an asymptomatic patient who has SVG lesions. On the other hand, if you talk about chronic total occlusion without SVGs, these patients are almost always ischemic. In this study from Dr. Barry Uretsky, published in 2014, they looked at about 100 patients. 50 of them had chronic total occlusion successfully revascularized with stents, and they used with 50 control patients who had an abnormal FFR and underwent PCI. They found that the chronic total occlusions were longer, and they required more stents, which is normal. You know, usually when there is a chronic total occlusion, there is longer length of lesion, longer stents are required. But prior to PCI, FFR was lower with CTO. So in all the patients, you can see that the FFR was very significant, 0.45 as compared to controls, which was abnormal, but the average was 0.58. And all CTO patients demonstrated an ischemic FFR. So all of the patients in this study were ischemic, despite that they have had a chronic total occlusion, that is their coronary artery is occluded for a long time, and still they have significant ischemia. It is not dead. Long-term outcomes after Cto Pci with Everolimus Eluding Stents. This study basically looked at how these newer stents, the newer generation stents, do in chronic total occlusions. They looked at about 250 consecutive patients, looked at 1 year major adverse cardiovascular events. The procedural success was 96%. And they found that compared with a pre-specified performance goal derived from 6 prior trials where they had used drug-eluting stents to treat chronic total occlusions, where 1 year major adverse event rate was 24%, with the use of Everolimus Eluding Stents, it was the 1 year adverse event rate was only 8.2%. So these stents have improved the 1 year outcomes in patients undergoing PCI with drug-eluting stents for chronic total occlusions. Also, the target lesion revascularization at 1 year was only 6%, which is quite good. So use of Everolimus Eluding stents should be strongly considered in patients who have chronic total occlusions. Moving on to how to revascularize. So I have so far talked about when to revascularize. I'll move on to how to revascularize SVGs and maybe CTOs a little bit. So what are the issues in SVG interventions? We know that there could be distal embolization, there could be no reflow, support issues can be there. Then I'm going to actually show a case where there is a retrograde segment from which needs PCI, and there is aneurysms, tortuosities, all of these issues come up. So first of all, distal embolization, how do we prevent that? So the important factor that is very underutilized is an embolic protection device. The guidelines from American College of Cardiology from 2015, they say that it's a class 1 indication to use embolic protection devices, these filter devices in SVGs. However, report from National Cardiovascular Data Registry, the Cath PCI registry, the use was only 10% back in 2010. So it is important to know that it is very underutilized. The other important complication that can happen is no reflow, and that is mainly because of plugging of microvasculature that can cause slow or no reflow. What predicts that? Presence of thrombus, acute coronary syndromes, degenerated vein grafts, or ulceration of the lesion. And if you're using a filter during an intervention of SVG, and if it is full, aspiration thrombectomy should be used before removing the filter. How do we treat no reflow? Nicardipine is very effective, but it is expensive. Nitroprusside works well. You just have to be careful about renal failure. And you can use nitroprusside and adenosine together, but just have to be careful that this can cause hypotension and bradycardia. But these medicines can be used in case of no reflow. Then how about, direct stenting? That is putting in a stent without using adjunctive angioplasty at all. Because if you imagine when you inflate a balloon in the SVG, there could be distal embolization of clot and tissue embolizing distally. So in this study, we looked at 575 patients from the DIVA randomized control trial between drug-eluting stents and bare metal stents from DIVA study for SVGs. 32% of patients underwent PCI with directly stenting, no balloon used at all. And what we found is that although the target vessel failure at 12 months was not different, 15% in stent only versus 19% in patients who had a balloon angioplasty done as well. However, when we looked at their other outcomes at a median follow-up of 2.7 years, the definite stent thrombosis was significantly less. The target vessel MI was also significantly less. And as this slide shows, the stent thrombosis decreases from 11% to 5% if you don't use a balloon, just put a stent in, and the target vessel MI reduces from 14% to 8%. I'm going to show a case here. So if you look at this SVG, this is SVG that is anastomosed to the RCA, and there is a stenosis in the retrograde segment. So we are using a 6 French system here. You can see how tortuous it is. We were able to wire it, get a balloon down. But then after that, we could not deliver a stent. So even though we used a 6 French guide liner, we could not deliver a stent because it would not make the U-turn. And despite using 2 wires and everything, it did not work. So the question is what to do. So what we did the next time, we used an 8 French system. We put an 8 French guide liner all the way down to the anastomosis. We put in 2 wires, so 1 wire down straight into the PDA, and 1 wire into the retrograde segment. Remember, the stenosis is here. Then we used actually a Corsair catheter that we use for chronic total occlusions, and we exchanged the wire from a whisper wire to an extra support wire. And then we delivered a stent. You can see here how the stent is making a U-turn, and stent A got in position. And then finally, this is our result. We were able to fix the blockage, and it got a very good result. So there are different tips and tricks for Svg Pci that should be kept in mind. That is to give preference to PCI of the native artery if feasible, particularly if the SVG is degenerated. Avoid balloon pre-dilatation, just direct stent, use a filter, utilize the vasodilators like nicardipine, nitroprusside, avoid post-dilation. If post-dilation is performed, size the balloon with a 1-to-1 graft. Do not be aggressive. Do not try to post-dilate like we do in the native coronary arteries. These are friable, so you don't have to go for a perfect result here. Consider thrombectomy if there is a heavy thrombus burden, and then prolonged dual antiplatelet therapy, because based on DAPT score, Svg Pci is a high risk for stent thrombosis. Now, a little bit of talk about PCI of native coronary artery versus saphenous vein graft. So this is a meta-analysis from Dr. Berlakis and his team, and they looked at multiple studies looking at about 14,000 patients, and they found that native artery PCI leads to much better outcomes of major adverse cardiac events compared to bypass graft PCI. So whenever you can fix the native artery, go for the native artery. Target vessel revascularization is also much better if you fix the native artery compared to SVGs, and target vessel myocardial infarction is also significantly less in patients who undergo native artery PCI compared to SVG of the same territory. So in this study, they looked at the outcomes. Essentially, they looked at 22 observational studies. And native artery PCI was associated with lower MACE, all-cause death, MI at 2 years, compared to stent in the SVG, which had much worse outcomes. Also, it is important to consider Cto Pci of the native artery when the saphenous vein graft is very degenerated. That is, the degeneration score, it has a lot of luminal irregularities and ectasia. If that occupies, especially if it occupies more than half of the graft and the degeneration score is 2 or 3, you're better off fixing the native artery than the SVG. Some clinical risk factors like older age, pre-procedural high diastolic blood pressure, diabetes, proximal lesion, these are also associated with worse outcomes. So I'm going to, finally, I want to just briefly talk about a novel concept with short and long-term approach. So you've got a patient who comes in with an acute MI, has a tight lesion in the saphenous vein graft, and the vein graft that the native artery that it is supplying, that's totally occluded. So of course the patient is sick, you've got to take care of that lesion acutely. So in this particular report of 2 cases, the operators in the first stage, they fixed the SVG, restoring good flow, and just finished the procedure. In the second stage, which they did a few weeks later, they actually brought the patient back to fix the native coronary artery to improve the outcomes for the long term. So here is this example. So you can see this is the SVG, and actually, and this is a wire in the native coronary artery. So this stent is actually going from SVG into the native coronary artery. So the anastomosis is blocked off with a stent. So they fixed this in the first setting. They tried to open, there was a stent there that caused the problem, but it was undersized stent and they could not make it better. Distal to the anastomosis, it was bigger, but at the point of anastomosis, it was kind of crimped. It would not open with a balloon. So they fixed that at that point, restored good flow and stopped. Then they brought the patient back and actually used the SVG for a retrograde wiring. They could not get retrograde. Then they tried antegrade. Finally, they were able to do a reverse cart retrograde and then were able to advance a wire. But because remember, there is a stent at the anastomosis, they actually went subintimal and then crossed the subintimal, crossed behind the pre-existing stent and then re-entered the native artery here with a Stingray balloon, and with a Stingray, which is a re-entry catheter. And then they crushed the previous stent and then got a very nice result in the native coronary artery finally. So this is much better in lasting for a long time to fix the native chronic total occlusion. So this is my final conclusion, that to consider PCI of asymptomatic patients, if you have a prognostic indication, like I showed in my first slide, I think that's a good idea to fix even if the patient is asymptomatic. For moderate to severe SVG stenosis, because the natural history of SVGs is that they will occlude over a period of time. So it is a good idea to revascularize those SVGs, even if the patient is asymptomatic. Abnormal FFR, even if that's beyond an SVG, is a good reason to fix it. And then consider native coronary PCI whenever possible for more durable long-term results. And finally, if there are high-risk findings on the stress test or LVEF is less than 35%, then I think it is a good idea to fix a patient who is asymptomatic. Thank you very much for your attention. I'm happy to take any questions.
Thank you, Professor Faisal Latif. I think the topic is very interesting for us. In Vietnam, the number of CABG cases is not much, so we don't have the experiences on PCI for the SVG. So we will have some question for you at the end of this session. And now we move to the third presentation, management of unrevascularizable symptomatic coronary disease, from Associate Professor Gregory Partners.
Thank you.
Yes.
Thank you very much. I'm going to share my screen here. And
yeah, I hear you clearly. Yeah, you can share your slide.
All right, let me do that. Apologize here.
The secretary, you may allow him to share the screen.
Here I go.
Thư ký ơi, em cho quyền cho.
Do you see the slides now?
Not yet.
I believe I'm sharing. And we'll try again.
Okay, you can share it now.
Okay. There.
Okay. Okay. It's clear now.
Great.
You can
All
start.
right.
Yeah.
Fantastic. Thank you. So I apologize for that, but I would like to say that the preceding talks were a wonderful introduction to this talk about managing unrevascularizable symptomatic coronary artery disease. We're going to talk about the disease progression that we see, that we just heard about from Dr. Latif. We're going to talk about the selection of revascularization and really the palliative nature of revascularization itself. As an interventional and critical care cardiologist, I see this disease spectrum on a variety, really across the spectrum of disease. And I've been caring for patients with unrevascularizable disease for the last 25 years. And so I'd like to share some of my experience with you. In the United States, there is a large cohort of patients with symptomatic coronary disease, and that group of patients is actually growing by the year. And unfortunately, although revascularization, as Dr. Jaffrey talked about in the first talk, revascularization can help with symptoms, all of these revascularization options that we have are only palliative, and there is disease progression and graft and stent failure. And so that there's a growing cohort of patients who have symptomatic, unrevascularizable coronary artery disease that's resistant to optimal medical therapy and attempts to revascularize. And this is true in Vietnam as well. It's difficult, this is a difficult patient population to recognize, but in Vietnam, where about 75% of deaths are related to non-communicable diseases, 1 in 3 deaths are related to coronary artery disease, and that is only patients who suffer death. There's a great number of patients who have significant risk factors, diabetes, obesity, smoking, and have symptomatic coronary disease and are suffering from that. In the United States, people with symptomatic coronary disease suffer economically as well as symptomatically. So patients 30% of the time don't return to work once they have refractory angina, and 15-20% of patients, even after revascularization, rate their health as poor. And so often we determine or list these patients as no option patients. You're put in a big group of people just that you can't do anything for. And there are more subtleties to it than that. And in fact, I'm going to show you that there are some options for these patients, and there's no such thing as a truly no option patient, I don't believe. A number of people have tried to define refractory angina. The definition I use is a 3-month duration of symptoms despite maximal anti-anginal therapy with one or more of the following phenotypes: either kind of diffuse multivessel disease, which we see frequently, limited territory disease, such as a CTO, vasculopathy with just diffuse disease, including stents or bypass graft, and end-stage disease with multiple graft failures, multiple vessels at risk. And so these are different phenotypes that require different thought process and different treatment options. The thing that all of these groups, however, have in common is that there is a significant mortality risk associated with patients with refractory angina. So in our cohort of patients now out to 10 years, there's a significant 30% overall mortality rate in these patients. However, just like in stable angina of other sorts and other patients with coronary disease, only about half the mortality, about an annualized rate of about 2%, is attributable to cardiac causes. So although there's a high mortality rate associated with patients with refractory angina, it's actually mostly it's at least half non-cardiovascular mortality. And so the annualized 2% mortality rate is difficult to improve upon. And what we really need to do is think about symptom control without increasing morbidity or mortality in these patients. So what sort of options do we have? Well, we have a variety of novel therapeutics. We can reduce myocardial demand and symptoms with things like ranolazine, other medications, standard guideline-directed medical therapy. There's spinal cord stimulation, which is implanted and is a good pain management strategy. We can improve myocardial supply through transmyocardial laser revascularization or therapeutic angiogenesis. There's a new coronary sinus reducer. There's shockwave therapy that I'll talk about later. You can even consider cardiac transplantation for these patients. There are devices with combined effects. I'm going to spend some time talking about external counterpulsation as a device to improve outcome and symptoms. And of course, optimizing the standard therapies with guideline-directed medical therapy, education, exercise, and risk factor modification. And importantly, as was just pointed out by Dr. Latif, CTO or complex revascularization of previously unapproachable lesions is a standard mechanism now for treating these patients with previously defined refractory angina. I will point out that even when people are defined as having refractory, unrevascularizable symptoms, about 15% of those patients are revascularized with a stent within the subsequent year. Often that's related to acute coronary syndromes and lesion progression, but sometimes it's approaching lesions that were felt to be unapproachable in the past. We do have, as I mentioned, novel therapeutics with proven benefit. L-arginine, ivabradine, ranolazine, nicorandil, and trimetazidine are available to use. The price varies, the risk profile varies, but they all have some improvement shown in randomized trials for ST segment depression time, total exercise time, and in some of these agents, improvement in myocardial perfusion imaging. So the medications can be helpful, but they're limited by cost and side effects. We have invasive treatment options, and there are limitations there too. Repeat revascularization or mechanical means of trying to revascularize patients is associated with reasonable success at 1 year, but very high mortality, morbidity. Redo bypass surgery, as was alluded to by Dr. Latif, can double or triple the initial risk of death. Transplantation has high risk associated. DMR or transmyocardial revascularization in isolation has relatively poor long-term success with very high mortality, morbidity, depending on the patient's substrate, especially in acute coronary syndromes. Sympathectomy can be used, spinal cord stimulation, and ECP. You see that those risks of mortality or morbidity are significantly lower, although the 1 year success varies from 50 to 70% with sympathectomy to 70 to nearly 90% with ECP. Central to all of this revascularization discussion is the endothelium. The endothelium, of course, is the largest organ in the body. It's impacted by a variety of the risk factors that we commonly associate with coronary artery disease, and endothelial dysfunction is directly associated with increased vulnerability for a variety of vascular disorders and complications, including dementia, heart failure, stroke, acute coronary syndrome, sudden death, and symptomatic coronary disease. So the endothelium, although it's often considered a diagnostic organ, you can tell if somebody has endothelial dysfunction by testing. It's actually a reasonable therapeutic target as well, and I'll show you why in a second. So endothelial homeostasis is critical to good vascular health and symptom control. In the normal endothelium, there's a balance between nitric oxide and endothelin factors. Remember that angiotensin 2 and endothelin are actually implicated in the COVID infection as well. So there are some other impacts of the COVID infection on the endothelium as well. But if there's good homeostasis, that leads to vasodilatory, antithrombotic, and antiproliferative effects, and that's an atheroprotective state. Endothelial dysfunction is a state where the bad actors, endothelin and angiotensin 2, outweigh any good effects of nitric oxide, prostaglandins, and what you end up with is vasoconstriction and atherogenesis and decreased endothelial repair and depletion of EPCs. This is important because when you look at endothelial function, when you test for it, you can see that the number of risk factors present in a patient is actually associated in a inverse function with the degree of endothelial dysfunction. So the worse endothelial function, the more risk factors are likely present. And abnormal endothelial function is also associated with worse outcomes. So there are increased cardiac events in patients who have measured endothelial dysfunction that's abnormal compared to normal endothelial function. Can you do anything about that? Well, actually you can. Exercise acts on endothelial function, and you see in this match set from several years ago of patients in an exercise or control group, you see endothelial function improved, and the exercise group stayed the same at 4 weeks. in the control group. So you can do something about endothelial function, something as simple as exercise. And that makes a difference for outcome as well. So if you are able to do something like exercise to improve your endothelial function, you can see that in the red line, your outcome is actually the risk of events is actually decreased compared to persistently impaired endothelial function. So doing something that affects in a positive way the endothelium is a good thing to do for patients. That brings us to ECP. Not everyone can exercise. And in people who can exercise, ECP is a ECG-gated inflation of cuffs on the lower extremities that milks blood into the central vasculature, including into the coronary arteries, and creates a lot of shear stress. It's provided over a 35-session course over a period of 7 weeks for an hour session at a time. And just like exercise, people start to feel better as they would initiating an exercise program. There are some reproducible hemodynamic effects. You see in the left-hand panel a Doppler signal from baseline and then applying ECP at a 1-to-1 rate. You can see there's marked diastolic augmentation in the coronaries. The central hemodynamics are similar to intra-aortic balloon pump counterpulsation. You can increase mean pressure by 20%, increase diastolic pressure by twofold, increase or get systolic unloading, and you actually increase the cardiac output by quite a bit through these parameters. So it affects the vasculature, and it affects the vasculature through the shear stress, just like exercise. There's a shear stress on the endothelium. That's got anti-thrombotic, anti-proliferative, pro-survival, and vasodilatory properties. Clinically, this leads to improvement in angina across all classes. So class 1 to 4, you see reductions in angina that's reproducible in clinical studies. You get improved quality of life. There's sustained benefits. There's a randomized sham-controlled trial demonstrating reduced anginal episodes, increased time to ST segment depression, reduction in nitrate use, and increased exercise tolerance. And there's beneficial modulation of physiologic markers and endothelial function. We look carefully at our patients with ECP testing or therapy, and we looked at their endothelial function before and after each session on a daily basis. And you can see that at the first day, mid-course, and on the final day of therapy, there's an improvement in endothelial function measured non-invasively. And this was a durable effect. So a 1 month following treatment, so no additional treatments, there was a statistically significant improvement into a normalish range for endothelial function after a course of ECP. So a dose-dependent, durable improvement in endothelial function. And we were able to associate that improvement in endothelial function with an improvement in angina class. You see in patients who had an angina class improvement, their endothelial function improved, whereas in the low minority of patients without symptomatic improvement, their endothelial function was not modulated. This was done in a blinded fashion. The same is true of quality of life scores. We went further to look at patients and their circulating progenitor cells. I told you that abnormal endothelial function has an adverse impact on endothelial precursor cells, decreases the number, and it impairs the function. We looked at the number of precursor cells. You see in the left panel HPCs, CD34-45 cells, CD34-135 cells, and CD34-45 cells vary in the normal state and the coronary endothelial dysfunction state. So the numbers are lower with dysfunction. And you see with ECP, there's a stepwise increase in endothelial function, in endothelial precursor cell numbers, which would go along with improvements in endothelial function itself. Other groups have seen similar findings. ECP has been associated with improvement in nitric oxide levels, flow-mediated dilatation, blood pressure, cellular adhesion molecules, inflammatory cytokines, and symptoms. And that includes in randomized trials with sham groups. So when we're thinking about endothelial function and modulation of that in order to improve symptoms. There are some things that we should be doing that includes good medical therapy. Goal-directed, guideline-directed medical therapy is essential. And part of that is because many of these factors act directly on the heart or on the endothelium in order to positively affect the patient's symptoms and functional status. As I said, although exercise is important in patients who can exercise, modalities such as ECP can be tried in order to affect these same changes on the endothelium and the symptoms. There are other ways to work on the vasculature that may have effects on the endothelium as well, and certainly may have symptomatic improvement. For many years now, we've been looking at gene therapy and cellular therapy for treatment of refractory angina. This is a slide I borrowed from Tim Henry showing the results of the RENEW series of trials. This is a series of trials that were performed. Stem cells were, or CD34 cells were harvested from bone marrow. They were processed and then re-injected into the myocardium of patients with angina. And in composite, they were able to show that there was an improvement in total exercise time, lower relative frequency of angina, and a significant decrease in all-cause mortality at 24 months. Very impressive findings. This awaits further validation in other blinded randomized trials, but it's a very good start. And I think we're closer to applicable and reliable cell therapy for our patients with vascular disease and angina. Another thing that can be tried is extracorporeal shockwave myocardial revascularization, or ESMR. This is available in Europe, not in the United States. It's been trialed in the United States. It's only been studied in some very small trials, but it's a echocardiographic guided low energy ultrasound shockwave device to address that's targeted to ischemic areas and creates microcavitations and disruption with local neoangiogenesis and vasodilatation. At least that's the proposed mechanism. It's delivered over 9 sessions of 1,000 shocks per session, and it has been associated with reduced hospitalizations, improved symptoms, and a modest change in exercise time, but again, also needs further validation studies. And kind of an exciting thing for an interventionalist like myself, the coronary sinus reducer is an implantable device that goes in the coronary sinus. It's actually a stent with a waist, as you see in the left panels. It goes into the coronary sinus. It actually reduces the flow coming out of the coronary sinus, leaving a pressure head behind that stent and theoretically propping open the microvasculature to improve perfusion. It has been shown to improve symptom class in patients who've had this tried, but the studies are primarily open label. It does require further validation, but it's a promising technique. And the nice thing about this is if something goes awry or it doesn't work, it can actually be re-expanded and that waste can be pushed aside with a balloon as if nothing is there at all. So what are my options and my management strategies for patients with unrevascularizable coronary disease? Well, the first thing is, and I put it in quotes, a second opinion, thinking again about how to optimize the symptom status and the outcome for a patient. That includes, of course, optimized medical therapies, including guideline-directed medical therapies, novel agents, encouraging exercise and risk modification, thinking about standard revascularizations, including CTO revascularization, if that is part of the problem. We then turn towards EECP, which has a Class 2A ESC indication, Class 2B AHA-ACC indication. And then if that is not appropriate or is not sufficient, we can think about spinal cord stimulation, TMLR, which actually has a Class 3 indication by the ECC or ESC guidelines at this point, or clinical investigations. And I put that in highlight because I think investigations of therapeutic angiogenesis, coronary sinus reducer, ESMR, and the like are very important for this underserved, relatively under-recognized population. And finally, I want to point out and again emphasize that endothelial dysfunction is associated with worse symptoms and impaired outcome. It's a central and unifying disorder, and optimal medical therapy and risk factor modification are essential because they act on the endothelium. They improve symptoms and outcome, just as was demonstrated in both of the previous talks. These effects are modulated via endothelial function effects. Exercise and vascular fitness are central, and the treatments directed at vascular homeostasis provide demonstrable symptoms and clinical benefit, as I mentioned in the talk. And with that, again, I would like to thank everyone here. Come on. And I look forward to joining you again in wonderful Vietnam at some time when we can all travel again and be together. Thank you very much.
Thank you, Professor Gregory Bartnas. I think your device is mean that the first time I heard about that, a very interesting presentation. Now we move to the discussion. I want to ask two panelists here, Dr. Củ Lợi and Dr. Nguyễn Đỗ Anh. We listened to you about your opinion about the indication for the CCS patient, indication for PCI for the patient with chronic coronary syndrome from Dr. Nguyễn Đỗ Anh.
Good morning. I think that the refractory angina patient, I think that this is a very interesting topic because in clinical practice, we also met some of the patients. They had this. Sorry, can you hear me?
Now it's okay.
Yes, already it's now.
Yeah, I think it's interesting the topic because in clinical practice we usually meet some patient with, even though we use the optimal medical treatment, the patient has still angina. Actually, in Vietnam now we just only we use the medical treatment only, and ECP I think is we don't have the experience about this. And also, even though we had some of the unfactorities, we also have the times of the angina, the patient relates to the micro, the coronary, the microvascular function. Also, I think that the two times that we met. Also, they have with two types. One is the patient with the epic is the C, the micro with the coronary microvascular dysfunction, and even though when we make the CAC, the coronary artery is normal. And the second related to some case with there's a severe coronary stenosis, the left main or triple vessel disease, but we cannot treat with any we cannot treat with the cabbage or the DCI, and also have to still just only the optimal treatment. That's it.
Okay, thank you, Professor Bartnas. What is the indication of PCI for the patient with CCS, chronic coronary syndrome, in your center?
Yeah, so I think it remains important to consider underlying medical therapy. So we will often, in patients who have established coronary disease, we will make sure that they're doing things like not doing bad things to themselves, so not smoking, exercising when they can, optimizing their their medical therapy, if they remain, because those are the prognostic features that Dr. Jaffrey mentioned in his talk. When they remain symptomatic, even if it's class 1, if they're on optimal medical therapy, often symptoms are reported as less severe than they actually are, because people learn to cope with the symptoms that they have. So they don't do things. They don't walk outside anymore. They don't get any exercise because they're unable to. And so we miss a lot of those patients. But in patients who are having symptoms and are already on optimal medical therapy, even if it's class 1, we will look for revascularizable lesions in order to assist them. And I view it as a way to get them to the point where they can exercise more on their own to improve their vascular health and do the things that they need to improve their prognosis. So in that way, revascularization is a prognostically important therapy because it allows people to do the right things to improve their health.
Yes, thank you. Dr. Jaffrey, do you think that we can use FFR for indication for PCI for the patient with CCS or not?
The answer is yes and no. I think yes, because if your FFR is abnormal, the data indicates that those patients do better if you revascularize, but you have to be clear about how they benefit. Most of the benefit is driven largely by repeat revascularization. In other words, if you treat them medically, they come back for repeat procedure. And FAME 2 kind of showed that while a lot of them come back for repeat revascularization, a lot of that repeat procedure is driven by non-ACS kind of chest symptoms. But we do use FFR as a means to decide whether or not we want to fix a lesion that is intermediate. But I think the whole spectrum, the ischemia trial is sort of suggesting that, a lot of these patients can be treated medically. Keep in mind that ischemia trial did not include people who had undergone FFR. It was only people who had ischemia on a nucleus or on a stress test. So you've got to make that distinction very clear.
Yes, yeah. Dr. Kulai, do you have any comment about the FFR for the CTO of the SVG?
Yeah, I think the stenosis and PCI for the SVG pose many issues. The first is the indication of cabbage for the patients with native stenosis. If the native vessel is not totally occluded, there is a competing flow in the bypass, and so the restenosis is higher rate during a short term. So when we make a decision for cabbage, what is the most important criteria for the native vessels? The second thing is, if it's not totally occluded, the FFR for the SVG stenosis is very confusing. So should we do an FFR before and after the PCI? So we can see that the difference may have some impact for the long-term results of the SVG stenosis. What do you think?
Yeah.
I take it if the question is towards me. So basically, the problem with SVG is that if once it degenerates, no matter if you do FFR guided PCI of the SVG, the outcomes are not great because over a period of time they tend to fail no matter how good a result you get. But sometimes, they do stay open at times. And I think the data that we have for FFR and SVGs is very minimal. So sometimes, the decision-making can be tough and you can utilize FFR as an adjunct, but I don't think I would use FFR on a routine basis for SVG because of the factors that you mentioned. There is comparative flow from the native artery if it is not a CTO, and sometimes there is comparative flow from the collateral circulation. So therefore, I think you have to be very careful in utilizing FFR in SVGs due to these multiple factors.
Thank you. I have some comment for Dr. Shafri about the implication of PCI in CCS. We can see that in the recent recommendation and guidelines, they talk about the ischemic burden more important than atherosclerotic burden. But in the subgroup analysis of the COURAGE trial, the ischemic burden doesn't impact on the outcome of the composites of the cardiac maze. But the atherosclerotic did. So what do you think about this discrepancy, and can we translate this to the daily practice?
So I think, as I showed that in my talk, we've always been led to believe based on observational data that, from the Hakamovich group, that as ischemic burden goes up, especially once it crosses 10%, and particularly when it crosses 20%, revascularization gives you a mortality benefit compared to medical therapy. But the ischemia trial showed that that's actually not the case, in the sense that it did not matter how much ischemia you had, medical therapy or revascularization had the same outcome other than symptoms. In terms of hard out endpoints, there was no difference. So I think that you kind of have to start looking at the ischemia paradigm from a different lens and start thinking that, well, ischemia, yes, it is a problem, but what is driving prognosis is actually the atherosclerosis burden. And so the more atherosclerosis you have, the worse the outcomes are. Having said that, the ischemia trial also showed that whether you had mild, moderate, or a lot of atherosclerosis, the outcomes were not different whether you treated them medically or you treated them with PCI. So the focus has to sort of shift now towards medical therapy as the initial step in patients with chronic coronary artery disease or chronic stable disease, unless symptoms is the primary concern. And this is not written in stone. It doesn't mean that if somebody has chronic stable disease with a lesion, 1 or 2 lesions, you treat them medically, that's the end of it. You can always revise that decision. And then if they continue to have symptoms, then open up the lesions. But the whole issue is that the initial step used to be that you could never treat them medically, and now I think it's the opposite, that you can treat them medically initially, and then reserve PCI for those who flunk your medical therapy and continue to have symptoms. But the driver has to be largely symptoms because burden of ischemia and burden of atherosclerosis, it really doesn't matter whether you revasc them or you treat them medically. The outcomes, the hard outcomes are the same.
Thank you. Now we don't have enough time for more discussion. So I would like to invite Professor Gregory Panas to do the summary of this session, please.
Thank you very much. And on behalf of my co-chairman and the panelists, I want to thank the participants, Dr. Latif and Dr. Jaffrey, for wonderful talks. The session was titled Controversies in Cardiology, Medications versus Revascularization. I would have to say that I don't see many controversies. I think revascularization and medications need to. It's necessary that they coexist, and we can't have really one without the other. And so I believe that medications and revascularization are appropriate as coronary disease exists along a spectrum, and we need to recognize that spectrum and the various treatment strategies that are available. We learned from Dr. Jaffrey in his talk that medications are necessary for improved prognosis. We learned that revascularization might be necessary component for symptom control. We then learned from Dr. Latif that saphenous vein grafts have an inexorable progression. There is no doubt that these palliative vein grafts will fail, and treating them appropriately is tricky because of the unique difficulties with treatment of lesions in vein grafts. And so those techniques such as lesion preparation, gentle care, and turning towards native revascularization in the presence of vein graft disease is critically important. And then at the other end of the spectrum, we talked about the importance of endothelial function in patients with unrevascularizable disease, and the importance of exercise, guideline directed medical therapy, and activity in improving both prognosis and symptoms. And with that, again, I would like to thank the organizers of this wonderful conference. It's been a great pleasure meeting all of you, and I look forward to seeing you in person in Vietnam in the very near future. Thank you very much.
So thank you very much. So I hope to see you in Vietnam in person.
Thank you. Thank you all.
Thank you.
Giá như tôi được chẩn đoán bệnh tăng huyết áp sớm hơn, và giá như tôi tuân thủ sự điều trị của bác sĩ tốt hơn, thì tôi sẽ không bị biến chứng như vậy.
Viatris, we aim to empower people worldwide to live healthier at every stage of life. We're dedicated to delivering increased access to the medicines patients need, regardless of geography or circumstance. Because at Viatris, we believe in healthcare, not as it is, but as it should be.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển
kể cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách.
I will open the session. Dear chairperson, dear colleague, we know that antiplatelet therapy is a standard treatment after PCI. After stenting in CCS or stenting in after BCS, the duration of DBT 6 months or 3 months after CCS, or 3 months or 6 months after ACS is very important to balance the risk of bleeding or the risk of thrombosis. And now many new recent study of duration of DBT released. Now we see the escalation form very strong to white cell drug to the less strong to white cell or to shorter the DBT. And therefore, we had this session to discuss how to balance between the risk of bleeding and the risk of thrombosis in patients after stenting, after CCS or after ACS. I'm very honored to co-chair with Dr. Lam Wan Lee. I present to you, Dr. Wan Lee, my co-chair. And first of all, for this session, I would like to present Dr. Wan Lee to presentation the topic, the escalation of antiplatelet therapy should be the first choice after PCI for ACS patient. This is very interesting topic. Yeah, please, I would like to present Dr. Wan Lee.
Let me get my slides up. Okay, can everybody see my slides?
Yeah.
Yes, okay. Thank you very much, Professor Juan, and thank you to the Vietnam National Heart Association for the opportunity to be part of your very exciting program. It is very good to be back here in Vietnam, even though it's only virtually this year. My topic for today is a very exciting new concept that's starting to emerge in the sense that we are starting to examine the question of de-escalation of antiplatelet therapy as the first choice after PCI for ACS patients. My talk originally was titled for chronic for CCS patients, but I actually made a mistake. But I think this mistake actually covers a much more interesting subgroup of patients, the highest thrombotic risk subgroup. So hopefully this mistake will result in a more exciting lecture for everyone. These are my conflicts of interest here. So everyone is familiar with the 2016 ACC guidelines, which are quite similar to the 2017 guidelines. And once again, I think here, after PCI in stable ischemic heart disease, we can see that in DES patients, the recommendation has been 6 months of clopidogrel. And in ACS patients, which everyone recognizes is a higher thrombotic risk subset of patients, you know, it's at least 12 months of clopidogrel, prasugrel, or ticagrelor. And we have since recognized that prasugrel and ticagrelor are better agents in the setting of ACS unless there's high bleeding risk. So this has been the mantra for the last several years, 12 months of prasugrel, ticagrelor, or clopidogrel in ACS patients post PCI. The second concept that we should examine together is the question of switching between oral P2Y12 inhibitors in the acute or early phase, which is defined as the first 30 days. And as you can see, from the international consensus document from 2017. Theoretically, everyone felt that when you switch in this phase, you should load the patients with clopidogrel, whether you are going from ticagrelor to clopidogrel or from prasugrel to clopidogrel. You must load at 600 milligrams theoretically. I hope to spend the next 15 minutes showing you that both of these concepts may not be as true today as they were back in 2016 and 2017. So what is the rationale for that de-escalation in ACS? We know that most reduction of ischemic events with DAT in ACS occurs early in the first few weeks to months. When you give higher DAT potency, you have more bleeding. Most bleeding with DAT occurs late in the months to years after the initiation of DAT. And so therefore, the idea has been maybe we can cut back on DAT at some point. What has allowed us to do this? We have new drug-eluting stents in the modification of design with the polymers and drugs, etc., have reduced the risk of stent thrombosis. Our interventional techniques have improved with higher use of IVUS and OCT to guide our procedures, and our bifurcational techniques have improved. And also secondary prevention, long-term therapy has improved. So what does that de-escalation mean? There are two primary strategies. Either, first of all, you can shorten the duration of your treatment, and my colleague, Professor Kyo from Burma, will be talking about this specific strategy shortly, where you stop the ADP antagonist earlier and just continue with aspirin monotherapy. So basically, going from DAT to SAT, but using SAT as your long term. You can also stop your aspirin earlier, as was done in the Twilight study, and continue with ADP antagonist monotherapy. The second primary strategy is to decrease the potency of your DAT therapy. You can do this by either decreasing the potency of DAT from high potency ADP antagonist prasugrel or ticagrelor to lower potency clopidogrel, or you can decrease the dose of your high potency DAT. And this has been explored with prasugrel, but not with ticagrelor in the early phase. Some studies have explored potency decrease immediately in some subgroups with mixed results. Otherwise, the timing of de-escalation is also a modifiable variable, as in, when do you do this? Do you do this at 1 month? Do you do this at 3 months? Do you do this at 6 months, etc.? Then there's the concept of guided modification versus unguided modification. With guided modification, you are basically testing for clopidogrel non-responsiveness, either using genetic CYP2C19 testing or platelet reactivity testing, with the goal of either upgrading or escalating your ADP antagonist to more potent antagonism, or downgrading your ADP antagonist to clopidogrel. And then finally, you have this big new concept of unguided de-escalation, where you are simply de-escalating without guided testing as standard practice. And so let's look at the evidence for that. The history of this de-escalation in ACS goes back to tropical ACS, which is a study that was published in 2017 in the Lancet by Dirk Sibbing's group from Germany. This was a European open-label, multi-center randomized trial with 1 year of follow-up. They had 2,610 patients, and they were high risk. 55% of them were STEMI, 45% were non-STEMIs, and then 50% had greater than 1 vessel. In this study, after index, they treated either patients with prasugrel for 1 year at 10 milligrams per day, or they treated them for 7 days with prasugrel. They then switched to clopidogrel without loading them. Then they did platelet function testing. And if they found that they were clopidogrel sensitive, they then just de-escalated continuously with clopidogrel. So basically prasugrel to clopidogrel at 1 week. Or if they were not responsive to clopidogrel, they continued prasugrel for the remainder of the 1 year. In this subgroup, this was not really contemporary because they had 77% DES use, 16% bare metal stent use, which most people don't do these days in ACS, and then also 7% bioabsorbable BVS use, which is not a good thing. Once again, no clopidogrel bolus. The PFT test that they use is not currently commercially available. And if they were non-responders, as we said, we switched back to prasugrel. And as with any European population, there were 39% non-responders to clopidogrel, and these were switched back to prasugrel. So what did they find? They found that with the combined endpoint, there was non-inferiority and no superiority with this strategy. So combined endpoint, non-inferiority. When they look at bleeding, this was also non-inferior in this strategy, and there was a trend towards less bleeding, but it was not statistically significant. And interestingly, the ischemic events as well were not higher. Okay, so not very, inspiring study. Interestingly, in the same year, from France, also published in the European Heart Journal in 2017, there was the first hint of this question: unguided de-escalation to clopidogrel at 30 days in ACS. This was a topic study called, it was a single center randomized trial with 1 year follow-up, 646 patients, 40% STEMI, 60% unstable angina. They even included 4% left main patients, and 15% had greater than one vessel treatment. So this is not a very high complexity beyond some of these left mains. They used prasugrel and ticagrelor initially, and then at 1 month, they switched to clopidogrel without loading their patients. And what did they find? They found here that the net primary endpoint was statistically better in the unguided de-escalation group to clopidogrel by almost 50% reduction in the net primary endpoint. Interestingly, despite the lack of loading at switching, there was no clustering of events at switching. Adherence to treatment was fairly good. There was no difference in ischemic events between the two groups. The benefit was all within less bleeding. So unguided 1 month, less bleeding, and therefore better net outcomes in 2017. So in 2019, there was an international updated expert consensus statement on platelet function and genetic testing for PCI. And what did they say? They based it a lot on the tropical ACS, results. They said that platelet function testing to screen for high platelet reactivity on clopidogrel when that de-escalation is contemplated may be considered in specific clinical scenarios, bleeding events, high bleeding risk, as an alternative to DAP with potent P2Y12. So even though the study was non-inferior, they say, so they use the terms like they're quite soft, may be considered, etc. At that point, they say that genotyping to screen for loss of function allows when DAP de-escalation is being considered is not recommended because of a lack of data from dedicated studies. And this was JACC Interventions 2019, so fairly recent. However, very shortly after that document was published, the popular genetics trial was published from Holland, and this is guided de-escalation in ACS using genotyping in primary PCI. So they randomized high thrombotic 2,500 STEMI patients to genotype guided versus standard. Genotyping results with the switch was available about 24 hours after the initial presentation. The loading was at the discretion of the physicians, and within the paper, I could not find how many patients were loaded. So ultimately, 61% of the genotype guided received clopidogrel and 39% ticagrelor or prasugrel, which is fairly consistent in European population. There was 85% treatment assignment adherence in 1 year, very low left main, 0.5% left main STEMIs, 48% greater than one vessel, 20% bifurcation. This is a fairly high risk, thrombotic risk group. More contemporary, 94% DS, 4% BMS, and only 1% yes. So what did they find? They found that the primary endpoint net ischemic bleeding was non-inferior and not superior. So no difference in the primary endpoint of combined ischemic and bleeding. But in the secondary endpoint, when you use the BARC2 bleeding as the definition, this was statistically significant. There was less bleeding with the genotype guided strategy versus the with the standard therapy. And don't forget, they switch at 24 hours, which is quite remarkable. The next year saw the publication of host-reduced polytech ACS, the first of two significant Korean studies. This is unguided de-escalation of prasugrel at 30 days. Korean open-label, multi-center randomized trial with 1 year follow-up. Here, they use 1 month of prasugrel at 10 milligrams, and then they randomize the patients half and half to continue 10 milligrams versus unguided, so no PFT or genetic testing, to 5 milligrams. And ultimately, big trial, 2,000, almost 300 patients, 15% STEMI, 25% non-STEMI, 50% multivessel, 3% left main, very high IVUS use, like with most Korean studies, 30%. And what did they find? They found that there was a significant difference in the primary endpoint of net ischemic versus bleeding, 10.1 to 7.2% for de-escalation unguided. The ischemic endpoints, the same pattern, no difference. And safety outcomes, everything was driven by a decrease in bleeding at 1 year, with no difference in ischemic endpoint. That's important. This led to then the publication of a network meta-analysis by Dr. Shoji's et al.'s group in the middle of this year, where they combined all studies in ACS and DAP. There were 2 studies. We've seen both of them, topic and host-reduced polytech ACS for unguided de-escalation. And when they compared against all other strategies, once again, no difference in primary efficacy outcome, but there's significant difference in primary bleeding outcome in this network meta-analysis. And I had the honor of writing the editorial in JACC for this paper. Just after that was published, we have more data now from TALUS AMI, unguided de-escalation, this time instead of prasugrel, from ticagrelor to clopidogrel at 30 days. South Korean multi-center open label non-inferiority PCI in AMI study, 54% STEMI, 46% non-STEMI, and 1 year follow-up. And you see the study design here. What did they find? Almost pretty much exactly the same thing. Once again, at 30 days, no clopidogrel loaded during the switch, no clustering of events in the switching, 1.2% left main, almost 30% multi-vessel PCI, almost 30% imaging guided. They found that at primary endpoint, de-escalation was superior by almost 50%, 8.2 to 4.6%. No difference in ischemic events at 1 year. Everything, once again, driven by bleeding difference at 1 year by about a 50% reduction. So this is very compelling data and different from anything that we have seen in our guidelines so far. And all of this is even more reassuring because of the fact that 2 of these larger studies were both in Korean populations. And as we are all familiar, there's the East Asian paradox, where East Asian populations have higher bleeding risk and lower ischemic risk. 50 to 60% of non-response in East Asians versus the 30% that we keep seeing in Europeans to clopidogrel. There's a higher response to ticagrelor and prasugrel at European dosing. And despite all of that, the PCI outcomes are good, despite the higher non-response to clopidogrel genetically. And because of this, within the Japanese guidelines, you can see that the Korean Society of Cardiology, ACC, ESC, all have the same doses, but Japanese Society of Cardiology actually uses lower dose of prasugrel, 20 milligrams loading, 3.75 maintenance versus 60 milligrams upfront of ticagrelor. How that applies to a Vietnamese, a Chinese, or a Singaporean or a Malaysian population, I'm not sure, but I think we are more on the Korean side. So conclusions from what we've seen thus far, ACS DAP de-escalation studies have evolved from guided to unguided. The strongest unguided data is in Korean East Asian patients with high clopidogrel reactivity. High clopidogrel non-reactivity. Guided results with PFT or genotyping are non-inferior. Unguided de-escalation data is superior to standard potent DAP therapy from the trials that we have seen. Interestingly, the thing that we are most worried about, there is no increase in ischemic stent thrombosis signal, even with de-escalation to clopidogrel at 1 month without loading. And all of this is driven simply by less bleeding. So the final thoughts. All of this has happened because we have a better and better DES and the safety is improving. Future research will continue to essentially test all the different combinations of backing off, just like with lipid therapy, until we will find no further benefit. So we need to find a new line. There is a possible benefit of shortening DAP. All the trials I've shown you thus far, it's still DAP all the way instead of going to monotherapy, but maybe switching to ADP agonist monotherapy or aspirin monotherapy might be fine. Although I don't think we'll get to aspirin. Is there a possible benefit with ADP agonist monotherapy upfront, straight to prasugrel, no aspirin anymore? If we get this right, there could be a huge financial potential impact with the cost of ticagrelor and prasugrel. However, I would say that we must always individualize because not all high thrombotic risk is captured in your enrolled populations. And remember, once again, that high bleed risk patients are also high thrombotic risk patients. We are almost certainly going to need further randomized trials in more specific cohorts, and the Europeans will obviously require that the studies are performed in European populations before they become integrated into guidelines. But this is likely a teaser or a hint of where we will ultimately end up in the next few years. Thank you very much.
Yeah, thank you very much. Dr. Wani, you present very interesting topic. And now, I hope that we understand more. We can de-escalation after stenting, after ACS. I think that is very practical for all of the interventionists in Vietnam. Next, I would like to present Professor Kto Win. Will present the shorter that should be the first choice after design for CCS patient. Please, Dr. Kto Win.
Good morning, everyone. First of all, I'd like to congratulate Vienna National Association for conducting this virtual conference successfully. I also thanks the organizing committee for inviting me to give this talk. Today, I'm going to talk about shorter depth should be the first choice after PCI in CCS patients. As we all know, indication for PCI in CCS patient is mainly for symptomatic improvement. But in some group of patients like left main, proximality, or multivessel disease with reduced ejection fraction, PCI has prognostic benefit in CCS patient. In coronary artery disease, there are two spectrum of clinical presentation, acute coronary syndrome and chronic coronary syndrome. In acute coronary syndrome, thrombotic complication following urgent PCI is related to ACA itself, whereas thrombotic complications following elective PCI in CCS is related mainly to PCI procedure itself. So to prevent thrombotic complication following PCI, antithrombotic therapy is essential pharmacological treatment. DABT with aspirin and P2Y inhibitors were proven to decrease stent-related thrombotic risk. However, the optimal duration of death is still controversial. In the era of bare-metal stents, the duration of death was only 1 month to prevent stent thrombosis. So in order to prevent a high rate of instant restenosis with bare-metal stent, DES were invented. Based on randomized controlled trials, 12-month depth was beneficial in reducing MACE following first generation DES, and 12-month DABT was recommended in previous guidelines after implanting drug-eluting stents. In 2006, World Congress of Cardiology, one question was raised: do DES increase death? Is it true? Yes. Cypher in Texas, the first generation DES had definite as well as possible stent thrombosis over 4-year period, and the survival rate as well as myocardial infarction rate were no difference between Everolimus Eluding Stents and bare metal stent with increased late stent thrombosis in Everolimus Eluding Stents. In ISA study, and this study proved the rate of stent thrombosis was increased with disruption of clopidogrel before 6 months after PCI. The late stent thrombosis and very late stent thrombosis after 1 year and 2 years after PCI were 0.3% and 0.2%. In Korean stent thrombosis registry, DES were associated with higher rates of stent thrombosis at 1 year. Japan CIFO and Dutch stent thrombosis registry, main reason for stent thrombosis was early stopping of either mono or dual antiplatelet therapy. The stent thrombosis is associated with high mortality, especially in STEMI patients. Due to fear of late stent thrombosis with first generation DES, the longer duration of dual antiplatelet therapy were recommended in previous guidelines. However, 1/3 to 40% of patients undergoing PCI are at high bleeding risk. The prolonged depth to prevent stent thrombosis has risk-benefit trade-off between ischemic and bleeding risk. That's why we need shorter depth treatment to reduce the bleeding risk. The major bleeding associated with higher mortality in CAD patients. So the strategies to reduce the risk of bleeding after PCI are de-escalation of antiplatelets or shortening of depth or aspirin-free strategy. The previous speaker has spoken about de-escalation of antiplatelet, and I will highlight about shorter duration of depth therapy. In fact, the depth duration is all about balance between death from bleeding and death from ischemic event. After PCI, both bleeding-related death and non-bleeding-related death were lower in short DAPT groups. So optimal duration of death needs to be individualized on balancing safety and efficacy after depth therapy. Let's have a look at results of trials on death duration after stenting. Initial studies have shown no difference in MACE and major bleeding between 6 months and 12 months DAPT. However, the depth trial was the first study to show benefit of shorter depth. The longer depth has lower MACE and less than thrombosis and higher rate of major bleeding significantly. So that trial concluded that the longer depth has lower MI and stent thrombosis with higher bleeding. Moreover, the longer depth has higher mortality, mainly driven by non-cardiovascular death. The risk of death from bleeding is higher than that of the stent thrombosis, and in patients with high bleeding rates and low ischemia rates, the shorter DAPT is necessary. Stop depth 2 trial comparing 1 month and 12-month DAPT. The 1-month DAPT was superior to 12-month depth at preventing NACE, and the 1-month depth was not inferior to 12-month depth at preventing ischemic events. The Korean study, the SMART choice, compared 3 months and 12-month DAPT following PCI. The 3-month DAPT was not inferior to 12 months depth in terms of MACE, and the bleeding was lower in 3 months depth group. In master depth trial, the 1-month depth after DES was as good as 3-month depth or longer duration. So how should we give that? Short DAPT, is it 1 month, 3 months, or 6 months? Longer DAPT, is it 12 months, 2 years, or indefinitely? And to which patient? It will need to individualize according to patient's thrombotic risk and ischemic risk by using risk assessment model. The depth score, precise depth score, and Paris score for suitability of longer duration after PCI. But the decision is difficult in real-world setting. In theory, the depth duration is all about balance between death from bleeding, and death from ischemic event. In reality, the ischemic events, bleeding events, and mortality are in common swell and the clustering effect. So one size doesn't fit all. We need comprehensive clinical evaluation focusing on ischemic risk, bleeding risk, patient clinical profile, stent type used, and PCI complexity. So novel approach for depth type and duration after PCI on CCS patients should be focused on treatment indication, either stable CAD or ACS, the patient characteristic, PCI complexity, type of device use, and estimating bleeding risk. So regarding patient characteristic, this meta-analysis of 6 RCTs regarding elderly patient group, in under 65-year age group, the longer death had lower MI, stent thrombosis, and stroke. Whereas in over 65-year age group, the longer death had higher MI, stent thrombosis, and stroke. The older the patient, the higher the complication with longer death duration. The senior trial also show in over 75-year age group, 1 month death for CCS and 6 month death for ACS, PCI using Everolimus Eluding Stents were better than bare metal stent. So regarding clinical presentation, in ACS patient, shorter death has higher rate of MI and stent thrombosis after PCI compared to CCS, but the rate of bleeding was no difference after PCI in between ACS and CCS patient. So patient baseline ischemic risk is lowest in stable CAD patient and highest in acute myocardial infarction. So US and European guidelines recommended death for 3 to 6 months in CCX and 6 to 12 months in ACS. Whereas Japanese guideline recommended 1 to 3 months for CCS and the same recommendation for acute coronary syndrome. How about the stent type? So the first generation DES had higher rate of stent thrombosis, but the second generation DES are safer and less stent thrombosis because they have less inflammation with new polymers and polymer-free DES or reduced stent struct thickness and easier to implant. Second generation DES does not need extended duration or depth to prevent stent thrombosis. So for this reason, shorter duration or depth, 1 month and 3 months, maximum 6 months is needed for newer generation DES. In LEADERS trial, 1 month DAPT was used, and biofreedom drug-coated stent is safe and more effective than bare metal stent. In senior trial, the Synergy drug-eluting stent showed superior result with bare metal stent in elderly patients that receive shorter depth duration. In Onyx trial, Resolute Onyx DES was safe and effective with 1 month depth duration. In DPAC trial, the use of DCB was superior to bare metal stent implantation in de novo lesion and high bleeding risk. The depth was used for 1 month only in this trial. Some more studies using short depth and comparing DES are expected in 2022 and 2023. The VVS are more thrombogenic and at least 12-month DAPT is necessary after the PCI. How about PCI complexity? So the more complex the PCI, the longer the duration of depth is necessary. All in all, longer depth is associated with lower risk of stent thrombosis and myocardial infarction. The shorter depth is associated with lower risk of clinically significant bleeding and all-cause mortality. So what recommendation on depth duration in current guidelines? In 2017 ESC guideline for CCS, whatever the stent type is used, 1 month death for high bleeding risks and 6 month death for non-high bleeding risks are recommended. In 2018, ESC and EACT guideline recommended 12 months death for BVS and 6 month death for DEV. So should short-term death be the first choice after PCI for CCS patient? Answer is yes. Those who have high bleeding risks and low thrombotic risk, 3 to 6 month death is necessary. And those who have intermediate risk, at least 1 year death is necessary. In higher thrombotic risk, the more than 1 year death may be beneficial. So the death duration will depend on PCI indication, type of DES used, and the patient bleeding risk. However, some selected patients may need longer death duration. The patient with prior myocardial infarction, stroke, and peripheral arterial diseases may benefit from longer duration of death therapy. In conclusion, the death strategies are not static. It needs dynamic decisions. The patient's thrombotic risk and the bleeding risk may change during follow-up. And patient may not tolerate DABD in long term as well. So the final death strategy may not be the same as DABD strategy after PCR. Thank you very much.
All right. Thank you very much, Professor Kyo, for that fascinating lecture with the excellent summary of the science behind shortening that duration, especially in CCS patients. I think in the interest of time, instead of engaging in the panel discussion at this point, let us move forward to the next talk, and hopefully at the end of the session, we will have time to discuss all of the concepts that have been presented to us. Next up, we have Dr. Nguyen Quoc Thai from the Vietnam National Heart Institute in Hanoi. And I think he's the director of cardiology at the Vietnam National Heart Institute. And he will be speaking to us about the management of DAP after complex left main stenting. So a very high thrombotic risk subgroup of patients, quite similar to the patients I was talking about in the beginning, patients with ACS. Do we have sound?
Can you hear me?
Yes, we can hear you now.
Yeah. According to the definition, the complex bifurcation lesion were defined as the one major criteria plus any two minor criteria in left main is including cyprine diameter stenosis more than 70% and cyprine lesion length more than 10 mm. Other feature associated with cyprine chromite from Asian Pacific is the F1 intravascular imaging, left main stenosis by IVERS or third complex MMA less than 3.7 mm, plaque burden more than 56% or calcified. is the left main bifurcation. And about the editor from the Lozano class, the interesting hypothesis suggests the maintained DLPT until 12 months. Compare